It is really from this mindset of support that the idea of creating a national community of experts in pediatric cardiac intensive care developed. In Canada, we have a population of 37.6 million people flung across a vast geography. About 400,000 children were born in Canada last year. That means that 4,000 additional children with congenital heart disease are born, and 800 children requiring intervention within the first year of life present to our centers. In Canada, we have 8 centers where these interventions can happen. In contrast, the US has a slightly less than 10-fold higher population with about 328 million people, and its birth rate is similar, where about 4 million children were born last year. That means 33,000 children with congenital heart disease were born in 2019, and 6,600 children who required an intervention within that first year of life. In the US, however, there are 125 programs where these interventions can happen, a 2-fold increase in capacity over Canada on a per capita basis. So although we look south to our American neighbors for ideas, motivations, and innovations, it seemed to many of us that we face unique challenges in Canada that require a uniquely Canadian perspective in terms of solutions. In early January, a number of us became engaged in developing this community and saw an opportunity when the Canadian Cardiovascular Congress was to happen in Edmonton. Our initial goal was to create a satellite conference that we were, with the Canadian Cardiovascular Congress as our goal, to connect with the very community that we work closely with each day, namely pediatric cardiologists, pediatric cardiac surgeons, and pediatric anesthesiologists. For many reasons, we could not coordinate with the CCC timings this year, and our focus became to support a virtual platform for this conference. We hope that this might change going forward as engagement and interest in the focus of this conference becomes apparent. Over the next 3 days, we hope you will get a sense of the broad expertise and engagement in pediatric cardiac intensive care and pediatric cardiovascular medicine that exists across this country. We are fortunate to have 3 keynote lectures named after 3 icons of pediatric cardiovascular medicine in this country. As we develop our community and its contributions to the discipline for the future, it is important we recognize what individuals like Dr. Ollie, Dr. Abbott, and Dr. Mustard have contributed to welfare of children worldwide. We have some truly fantastic keynote speakers as part of the program, and we are thrilled to have them as part of our conference. We have a fantastic group of moderators and speakers that represent expertise in many of the aspects of care that we provide every day to our patients. Finally, the last sessions on day 1 and day 2 will feature our top abstract presentations and top interesting case presentations respectively. We really hope you will stay linked for this important part of our programming. A final word about the nature of Zoom webinars. As a registrant in this webinar, you may have noticed that you have been automatically muted and your webcam has been disabled. In this webinar, you will have 3 ways to interact with moderators and speakers, and we encourage you to use them all. First, you will have the chat box. The chat box allows you to ask broad questions and make comments to registrants, moderators, and speakers. It is important for you to know that this area is not where questions for the moderators and speakers are best sent. Where we encourage you to enter your questions is in the question and answer box. Others can vote on the popularity of your questions, and this will be indicated to the moderators. I will ask our moderators and speakers to look through the question and answer box after their session is complete and try to answer questions that they didn't have time to address during the session. Finally, some speakers may ask you to participate in a poll. We would love to get audience participation in these, so please do your best to respond. Finally, at the conclusion of the conference, you will receive a SurveyMonkey link for a conference evaluation. When you receive your evaluation, you will receive a certificate of attendance via email. After a few weeks, you should also find the video of this conference on our YouTube channel, which you can link to from our conference website. So without further ado, I now have the great pleasure of introducing my colleague, Dr. Baruch Toledano. Dr. Toledano is the medical director of the PICU at Saint-Justine Hospital in Montreal. He's an associate professor in the Department of Pediatrics and a member of our 2020 program committee. Dr. Toledano will serve as the moderator for today's program. Dr. Toledano?
Great. Thank you very much. I have a really pleasure to present people I admire and people I know very well. So it's I couldn't be luckier and consider myself very, very lucky. We're going to start the session with the Dr. Peter Ollie Lecture in Pediatric Cardiovascular Medicine. And Dr. Peter Ollie was born in April 1937 in Manchester, England. He graduated from the University of London with a Bachelor's of Medicine and Science, and immigrated to Canada into Toronto, and was a research fellow in the Division of Cardiology and becoming the director of a cardiovascular research at the Hospital for Sick Children. He's most proud of the research work he did that led to the innovative treatment for newborn infants, which is the development of prostaglandin E1. And this is something that is used every day, many times a day in many pediatric cardiac intensive cares. This has allows us to stabilize children and then perform important surgeries and in the neonatal period. Dr. Ollie passed away in 2018, but we're consider ourselves very lucky that we were able to have his name on our first lecture for this conference. And as lucky we have is to have Dr. Gil Wernovsky be the presenter. And Dr. Wernovsky is, yeah, he's waving, is a senior consultant in cardiac critical care at the National Medical Center, and has multiple appointments in terms of being at Cornell, Harvard, and University of Pennsylvania, worked at Boston Children's, the Children's Hospital of Philadelphia, and Nicholas Children's Hospital. He's the founding member of a Pediatric Cardiac Intensive Care Society, the Cardiac Neurodevelopmental Outcome Collaborative, the World Society for Pediatric and Congenital Cardiac Surgery, and the International Society for Pediatric Mechanical Cardiopulmonary Support. He's also the incoming chair of the 8th, hard word to pronounce, quadrennial World Congress of Pediatric Cardiology and Cardiac Surgery, which we hope will be held in September 2023 in Washington, DC. And the one thing that everybody who knows Dr. Wernovsky tells me, he is a mentor. He's been involved in the training of many, many fellows in pediatric cardiology, in pediatric anesthesia, in pediatric intensive care, in cardiac surgery. And people who have not trained with him still consider him a mentor. Many of the people I work with consider him a mentor, whether it be having to do with cardiac surgery and sometimes even music. So that's something that people hold him, he's held very as an important person in our community. He's really been involved in the area of neurodevelopment, and his career goals is to identify modifiable factors in the care of children with complex congenital heart disease to improve overall outcome, longevity, school performance, and quality of life through a holistic interdisciplinary approach. We're thrilled to have you, Dr. Wernovsky, starting off our conference.
Thanks, Baruch. I need to be able to share my screen. Thank you. I'm really so incredibly honored to be the first recipient of this lectureship. There's really not much I can say. I mean, I love the fact that Zoom has allowed us to learn from a distance during this really difficult and incredibly ongoing difficult time. What I miss is being able to see people in the audience and see my friends. We were talking a little bit before about the other parts of face-to-face meetings, you know, the so-called hallway track where you get ideas and meet people. And I miss that, and I hope that we can all do it soon. And as you mentioned, the World Congress is still scheduled to take place here in Washington, but now in 2023. The topic, when I was speaking with Ben and others about what to speak about, we were trying to think of a variety of things that might span a little bit of history and a little bit of future directions. And we came upon the topic of, is neuroprotection really possible in the cardiac ICU? Let me just see if these can. So what I'm going to try to accomplish in the next 40 minutes or so is talk a little bit about where the specialty came from, how we evolved. Of course, you need to know that. We need to know that to sort of figure out what our next steps are going to be. I had one of those tipping points in my outpatient clinic that really changed my practice dramatically. I'm going to describe for you. We'll talk a little bit about the etiologies of neurodevelopmental disabilities and how we play a role in the cardiac intensive care unit. And then we'll talk a little bit about the model that we've designed here at Children's National Hospital and talk about the kind of things that I think will be applicable to all of you. I think these are my disclosures. Yes, for some reason, okay. I don't have any conflicts of interest or perceived conflicts of interest. I am a clinician. I am not a neurologist or a psychologist or developmental pediatrician. So I'm going to talk about this mainly from the perspective of those of us at the bedside. So I'm going to start with the conclusion. Is neuroprotection possible when you're dealing with a baby like this one here on BiVAD support with all this machinery and all the rest of it? Part of it is to not lose our focus that we're taking care of a little baby. There's a baby in the midst of all of that. And we still can do some things to protect the brain of that baby. Some of you can see this little butterfly up around here. Probably not doing too much now, but it's a symbol. I borrowed this slide from my good friend, Melissa Jones, who runs our program in the ICU. And I think it's very telling to compare what should be happening to the developing brain in the first month or 2 or 3 of life compared to what these babies and families need to go through. So one of the things we'll be talking about is this balance of minimizing the effects of the hostile environment of the cardiac intensive care unit and maximizing neurogenesis and healthy family bonding during this very difficult time. In other words, can we do this? Can we rethink how we provide care in the intensive care unit, that this type of care is as important as a BiVAD? And I apologize for the noise in the background. A lot of what I'll be talking about will come from 2 papers, one from my good friend and colleague, Dan Licht, and I, that we wrote in Pediatric Critical Care Medicine. And Dan and I have been colleagues doing this for about 20 years or so now. For those of you interested, this central figure will be of help where you might be able to think about the things you want to do in your intensive care unit. This is a photo of Amy Jo Lasanti. I met Amy Jo as a brand new graduate nurse right out of nursing school. She, within about 10 years, distinguished herself as a nursing scientist, got her PhD, and has really pushed the field forward of neurodevelopmental care in cardiac patients in particular. And again, I'm not going to go through these figures. They're busy on purpose because there is a lot that we can do for our patients now in the intensive care unit. So is neuroprotection possible? I would say neuroprotection is mandatory. We can't just ignore that and say the neurosystem is about fentanyl and neuromuscular blockade. What are we doing to improve neurogenesis? And we'll talk about some of these things. But we have to start with, what do we do, right? What's a cardiac intensivist? Well, as a cardiologist, I like to think that I'm a cardiologist who thinks like an intensivist. My colleagues that are intensivists like to say that they're an intensivist who thinks like a cardiologist. Our hospital money people say that not only are we double boarded in cardiology and critical care medicine, but a cardiologist who bills like an intensivist. And that's not relevant to much of you in Canada, but it certainly becomes an issue down here in the ridiculous fee-for-service health system that we have. Not that I'll get into any political statements. I don't know if a parent knows what this is, but I thought I'd give you my definition, which is a physician who dedicates their clinical career to caring for critically ill children with cardiovascular disease. Frankly, I don't care what certificate you have on the wall or what boards you have, but if your clinical practice is all with these children, you are a cardiac intensivist. You can't dabble in this field. You can't sort of do this 4 weeks a year and do other things other times. it requires a lot of dedication. You need a knowledge base that includes all the different types of heart disease, the transitional circulation, pulmonary hypertension, all the different surgical repairs and what they can bring to the table, and all that list of things in the knowledge base. And that's just a start of it. And then technical skills that would go from a tiny neonate all the way up to an adult with congenital heart disease. Down at the bottom, you need to be able to, your unit at least needs to be able to re-explore the chest and put in tubes and do an echocardiogram and take a kid to the cath lab. So really, other than being Mr. Incredible, there is no one person who possesses all these characteristics. You have to be part of a team where you know what everyone's strengths are and capitalize on those strengths. I wrote this slide a couple of decades or so ago, and I was looking back at it as I was preparing this talk, and I realized the brain was not even on the list. So when we talk about innovation and change and where do we want our field to head, it's helpful to sort of redefine progress. Now, most of us think that progress is this, as Sidney Pollard once said, this Victorian ideal of progress. And what he said was the assumption in Western cultural tradition that a pattern of change exists in the history of mankind that consists of irreversible changes in one direction only, and that this direction is towards improvement. And although we may think that is the case, that is because we forget the evolutionary dead ends of things we don't do anymore. And I can give you a number of different things, such as old style Fontans, resecting sub-AS without a gradient, and a variety of medications that are out of fashion right now. We are definitely always for change. We like to think that progress is a straight line, but it tends to go more like this, with ups and downs. Now, those of us who work in the ICU, we want progress, but we're resistant to change. And I'm sure the people in the unit know what I'm talking about. If somebody comes in with wanting to use a new medication or vent strategy, or even change the flow sheets or the settings on Cerner, there's resistance to change. It's just who we are as human nature. So we want the progress, but we're resistant to the things that might be necessary for it. And then there's the part about disruptive thinking. You probably are all familiar with this term. Disruptive thinking comes basically on 5 principles. That's a radically new relationship between resources, a solution that transforms a constraint into a benefit, radically changes the scale of an innovation. Clearly what was done with Bill Gates and Apple and Microsoft. Radically lower cost from higher volume. The group in Bangalore, I don't know if anyone is on the call from Bangalore, but it blows me away. They do 6,000 operations a year, or 12 a day, at a small fraction of the cost of any location in the world. They run their unit 724, 365. And then unearths a desire or a market that no one thought was there, like Facebook. I remember when Netflix used to be these little envelopes you would send back and they would come back, and things just are constantly changing, both in a linear fashion, but also in a disruptive fashion. And that's where we come to this statement and this graph. What happens in our field is a little bit of progress, and then boom, something happens, say a BT shunt. And the field moves on and say, hey, now we have cardiopulmonary bypass. And now we have a bunch of other things. And this is the way our field tends to leap forward, but it's hard to know when you're in the middle of a disruptive change that you're actually in it until you go forward and then look back on it. Now, we all want progress, but we're especially resistant to disruptive changes. And you all can imagine what those changes might be in your own place. So if we look at cardiac intensive care, as I mentioned, there could be the BT shunt and there can be cardiopulmonary bypass, but I don't think there was anything more disruptive to our field than the simultaneous introduction of bedside echocardiography and the institution of prostaglandin, developed by Ali and colleagues, of whom this lectureship is named. And I think many of the young generation don't know that name as much as they should. I have the same pictures that Baruch showed before. You heard his history, but it's worth reading this paper that is now 44 years old, which completely changed the landscape of what we do and led to the invention of other things. But I was looking at his bio and his PubMed, and I found this paper from 1977. So he too was interested not only in efficacy, but safety. And at the beginning of this, he realized the organ that was the most at risk in any new medication in a tiny newborn is the developing brain. I was really surprised to see this, and it was a relatively small group, but he found that it was safe based on EEG and neurologic examination. Without Peter Ollie, we would never have had the picture of Len Bailey and 15 transplanted babies with hypoplastic left heart syndrome in 1986. These are 2 patients of mine who had an arterial switch that were stabilized with prostaglandin. This is one of my favorite pictures. This is from when I was down at Miami Children's. And let me see if I can get that. The guy in pink here is a medical student. He's now a cardiology fellow named Tom Glenn. And they're operating on a baby with hypoplastic left heart syndrome, as you can see here, that Tom was so excited that he was scrubbing in on the case. Baby was stabilized with prostaglandin. The amazing thing to me anyway, is that Tom also has hypoplastic left heart syndrome. So I'm pretty sure that this is the first time that someone with a Norwood was scrubbing in on a Norwood. And none of this type of disruptive stuff would have ever been possible without the work of Dr. Ollie. So that was probably, those 2 were probably the 3rd and 4th most important disruptive events. And then that allowed us to do neonatal heart surgery, such as Norwoods and arterial switches and things we sort of take for granted in many of our units. That then led to probably one of the first real controversial disruptive leaps that I was sort of in the middle of in my career, which was the development of dedicated cardiac intensive care units. It became so contentious that there was actually a pro-con debate in the journal Pediatrics. And you may recognize the names on both sides of the article here. But I think we can say now that we're in 2020, the cardiac intensive care units are here to stay. So what's the next steps? Where are we going with all of this? Well, we've had these disruptive events, as you can see there. What we did not anticipate when we started doing all these operations back in the 80s and 90s was what was going to happen as these kids got to school. We primarily were taught, and we're sure it was true, that other than the heart, the babies are fine. The babies are normal. And that perioperative seizures were nothing to worry about. This was actually things as a cardiology fellow that I was taught. And I was initially at Children's Hospital in Boston, where there were, we did about 80 switches a year and about 50 Norwoods a year. And then I went down to Philly, where we were doing around 100 Norwoods a year. And this was, in the 80s and 90s. So now these kids are about 25. I also had an outpatient clinic, and this is the aha moment that changed everything that I was doing. I was in the clinic waiting, and I have permission to tell this story from Mom and the patient, whose name is Jonathan. And Jonathan came to the clinic. This is not him. This is Google images. But Jonathan could have been one of these guys. He came in with the hoodie, and he had the game thing going on, and he wanted absolutely no part of this office visit with this doctor. He just wanted to see his friends. And his mother said, "Will you excuse me, Jonathan? I have some things I want to talk to the doctor." And I'm thinking, oh, he's got problems in school or whatever. She was not happy. This also is not her. She was not happy at all. And it relates to a paper that I had written I had helped write in 2004, published in 2005 on the late neurodevelopmental outcome after TAPVR. It turns out Jonathan had TAPVR and was doing well from a hemodynamic perspective. And the mom reached in her bag and she pulled out this paper and she read the conclusion that said, unrecognized and inadequately met educational needs might be a source of frustration for children with TAPVC. Some might benefit from early intervention. Neuropsychologic evaluation of patients with TAPVC operated on during infancy is warranted to identify long-term neurocognitive defects. And she looked back at me and she said, "You've known about this for 3 years and you didn't tell me. And then even more importantly, what are you doing about it?" And it was one of those moments where I had been involved in a bunch of papers where we said neurodevelopmental follow-up is warranted or something like that. But who was responsible for that? we might have known about that as clinicians, but who takes care of that? And that led to the start of our outpatient neurocardiac care program in Philadelphia. It paralleled the one that opened at Children's National, where I am now, and at Boston Children's, and now there are many of these that have moved around. And at my institution, it was because of that particular clinic visit that happened. What are you going to do about it? And that's going to be a theme as we move forward through the rest of my talk, because what we've learned over time as outpatients, kids that have had congenital or critical congenital heart disease who need operations, they've been shown consistently to have a higher risk of certain neurodevelopmental disabilities. About 50% will have attention deficit, 40% with deficits in social cognition, executive function, and alexithymia, which is the ability to know your own feelings or the feelings of others, which is social cognition. Hard to make friends. About a third with oral motor or then gross motor or fine motor dysfunction. Again, about a third with apraxia of speech. 20% with mood disorders such as anxiety and depression or bipolar and personality disorders. 20% of them have a cognitive disability, and 10% have an autism spectrum disorder. Now, it's important for me to emphasize a couple of things. The first is that not all children have them. And a lot of times I'll hear the statement is kids with heart disease have neurodevelopmental problems. No, half to 2/3 are normal. However, they're much more common than the population of kids that have structurally normal hearts. At least 30% of the families will have PTSD for a long period of time and other parental mental health challenges. And this is an area we're going to talk about in a little bit. All of these factors are important contributors to a worse health-related quality of life. The first question we ask is, why do they occur? And then I'm going to constantly get back to, well, what are you doing about it? If we look at this in a linear fashion, many of the papers used to say the outpatient findings, and then more recent papers have said the outpatient findings and whether a prenatal diagnosis was made. Or the fetal cardiologist will look at, we know what's happening to the brain of the fetus, then they get the outpatient findings, and what sort of gets measured in the intensive care unit is very blunt measurements. How many days were you there? How many days were you on the ventilator? Did you have a cardiac arrest or ECMO? How long was the bypass time? But as those of us who work in intensive care know, there's a lot of stuff besides that that could affect the developing brain. And that's what we're trying to get a handle of. So this is the list of the things. You can find this in the American Heart Association scientific statement. Brad Marino is the first author. The important thing I want to emphasize is that these consequences are more common than all of the cardiac consequences combined. Endocarditis, arrhythmia, exercise intolerance, mediastinitis. If mediastinitis happened in 50% of our patients, there would be a root cause analysis and an incredible amount of resources to get there and say, we have to treat this mediastinitis. But if 50% of moms have clinical depression or 30% of kids are held back in a grade, where does that treatment come from? Where does that interest come from? So a lot of that is then what do you define as a good outcome? And I've informally polled a number of my colleagues who might be on the call, and you probably didn't know that you were going to be mentioned in this talk, but some think if I did my job, then the baby got sent out to the step-down unit, or we shortened the length of stay of that baby. Or the baby survived to hospital discharge. And this is a very short-term myopic view of outcome for kids with congenital heart disease. It's necessary, but it's insufficient. If I were to say what families would expect, that would be survival with the longest duration and quality of life. And this starts in the intensive care unit. So it's a good surgical outcome and no secondary brain injury, acute kidney infection, no vascular access problems, no phrenic nerve injury, and families that felt well supported. So with apologies to Darwin, survival of the fittest is insufficient. Our patients are surviving. Will they be able to drive a car, learn a second language, play a musical instrument? These are the real humanistic things that we cannot forget that we're trying to protect when we get these fragile little babies and infants getting heart disease. They need to survive and thrive. And I think this is the most important challenge in what we do now. I'm making the assumptions that surgery is good and hemodynamic care is good. This is the next area that we can take. Just a few patients I always like to show. There's Tom Glenn again, the young man with hypoplastic left heart syndrome. Again, to put in perspective that adult congenital heart disease patients were once your neonate. So that takes me to where my career has gone and what we'll be talking about now. And to quote Woody Allen, the brain is my second favorite organ after the heart. So why does this happen and what are we doing about it? So we've gotten to our disruptive events. And now we have to think about what can we do about neuroprotection, which I think we will be probably the next phase of what we do. And 10 years ago, 15 years ago, must be the surgeons. And certainly surgeons didn't allow neurologists in the ICU for the first 2 decades of my career, thinking that if the baby had a problem, it was because of the surgery. Now, we know that cardiopulmonary bypass, if done poorly, can cause damage. There's been a lot of work done on the effects of circulatory support. Let's take these 3 very bright Canadian surgeons, and they're thinking about what they want to do to protect the brain. So they want to maybe not use deep hypothermic circulatory arrest, shown there in red. So this is a 3-kilogram baby with transposition getting an arterial switch. They want to reduce the time on cardiopulmonary bypass. They're going to be focusing in on that sliver and making it better. There have been countless papers that I am not going to go through with you about this. And there are ways to make bypass better, and there are ways to make surrogate patient biomarkers better. However, when one looks at older patients, the effects of cardiopulmonary bypass on the variance in scores, on Bailey tests, on WISC tests, on motor tests, on any of those sorts of things, is less than 5% of the variance. So if it's not the surgery, what is it? How can I help? How can we help in the cardiac intensive care unit? How do we look at this black box and say, how do we separate out some of the things that happen? So I want to get to these factors, the preoperative risk factors, the postoperative risk factors, and how we can get a handle on parental stress and anxiety. The first myth to talk about related to this is the baby is stable on prostaglandin. Babies are not stable on prostaglandin. Any baby with a duct has heart failure. It may improve their saturations or mixing, or give them pulmonary blood flow or systemic blood flow. But the longer one waits with an open ductus, the more blood goes into the lungs. Plus you can get that rash. So given that these babies are in congestive heart failure, it puts their organs at risk. And what do we see? We see necrotizing enterocolitis. We see elevations of cerebral vascular, decreases in cerebral vascular resistance. We see the need for breathing tubes and inotropic support. And importantly, we see a decrease in cerebral blood flow. This is some work that was published in 2004, but there's been a number of papers now, I'll go back to that, a number of papers now that have shown that every day cerebral blood flow falls in a baby with an open ductus and complex congenital heart disease, every single day. So the first work was done by I mentioned him before, Dan Licht. I didn't know this, but it turns out that normal cerebral blood flow is about 50 mLs per minute per gram of brain. I never like saying gram of brain. But in babies that are stable on prostaglandin, quote stable on prostaglandin, with congenital heart disease, at rest, this is the baby you think is well in the ICU, because I did. We deemed they were well enough to get down to the scanner. Their brain flow was half that of normal. And then again, there's you could look this stuff up on Scholar or PubMed, and you'll find dozens of paper that show this fall in cerebral blood flow every day. So keep that in mind. By electively delaying cardiac surgery, we are in the newborn with complex congenital heart disease, we're increasing the risk of white matter injury, possibly having long-term effects. We also know that it increases medical error and cost for these patients. Then they get to the operating room, and then there's anesthesia. And there's been a big hullabaloo about what the risks are of anesthesia. Obviously, pain is bad, and doing an operation on a moving target is bad. And Dean Andropoulos at Texas Children's was one of the first to look at this with their group. And they found, again, summarizing an extremely complex topic, that after adjusting for multiple relevant covariants, lower developmental scores at 12 months were independently associated with a greater volatile anesthetic exposure. It was also associated with new brain injury on MRI, and you'll see this in every paper, longer length of ICU stay. If you read a paper about neurodevelopmental outcomes and it doesn't have longer length of stay, A, I would love to see it, but B, you need to figure out why that might be. Laura Diaz, who worked with us in Philadelphia, and a large group of us, found basically the same thing. That an increasing cumulative exposure to volatile anesthetics. And you can imagine a child with a functional univentricular heart having a newborn operation, a bidirectional cavo-pulmonary connection, 2 heart catheterizations, et cetera. That's just the 4 times there in the OR or the cath lab. There were 1,610 encounters, and in our cohort, we went out to 4 years of age. And it turned out again that increasing exposure to anesthesia was associated with all these problems that I described before. All significance p less than 0.05. Laura also got a medical student to look at every single dose of midazolam and fentanyl. And this was before the electronic health record. And he went through every nursing flow sheet for 1,610 encounters, and again found that both fentanyl and benzodiazepine exposure was associated with worse scores. And that those of us on this call, most of us on this call, have direct influence on. So if we think about these 4 great intensivists right here on the left, and they're thinking about a slice of time that they're responsible for this 3-kilogram arterial switch, let's say it's about 2 weeks, that time that the surgeons and anesthesiologists were with them is a sliver compared to the 2 weeks that the child may be in the intensive care unit. But this is clearly an effect that we have a lot of, an area that we have a lot of potential effect on. What do we know? We know that there's low oxygen delivery in our patients. We've just talked about hypoxemia. Some of them have low systemic blood flow or cardiac output. I want to emphasize the risk of stroke from paradoxical embolus in our patients. This is a particularly nasty looking one. I don't know what you call these in your centers. When I was in Philadelphia, they were called, when I was in Children's National, they're called trains. But when I was in Philadelphia, they were called gangs. And I'll let you make your own conclusion about the name of what those are. But if we look closely, you can see what the problem is here. And the nurses do a fantastic job of getting rid of this stuff as best they can, but it's just about impossible to get rid of all of them. And in any patient that you have with a right to left shunt, whether it's pre-op or post-op, any air or particulate matter can go right up to the brain, cause many strokes and little areas that you can't see clinically. And many of the studies that look pre and post-operative, for example, kids with an arterial switch tend to not have a lot of stuff after surgery. Kids with HLHS, where they've had an MRI before and after and continue to have a right to left shunt risk after a Norwood operation, say, have a considerable amount of increased particulate stroke type matter after surgery. This is in the literature. That data is being recollected now. What are the other cumulative exposures that we have? Well, phthalates are an area that I didn't really know anything about. What they are, they're the plastics that make material soft, and they're widely used, like in these rubber ducks. They're widely used in hospital settings. They're in umbilical lines, IV tubing, Foley catheters, endotracheal tubes, cardiopulmonary bypass. Our kids get exposed to a ton of plastic chest tubes. And then this is a report out of Europe, which changed a lot of the ways I thought about this stuff, which they looked at circulating phthalates during critical illness and looked at one particular neurodevelopmental outcome, which is attention deficit and hyperactivity disorder. The plasma concentrate, this was in a general PICU that had some cardiac patients, but it was a mixed PICU cardiac population, not newborns. The plasma concentration of phthalates was measured in 100 healthy kids. I don't know how they got that done, and 449 kids in a PICU. The metabolites were not detected in healthy children and elevated in the PICU children as soon as they got into the admission and the first sample that was done. And then they decreased rapidly, but still remained 18 times higher until PICU discharge. So these kids definitely had plastic detectable in their bloodstream. And what was interesting about this particular study is that after adjusting for the covariance and the usual sorts of things, the harmful threshold for the DHEP, or phthalate metabolites, was independently associated with attention deficit disorder and impaired motor coordination. The ADD association was then confirmed in a second validation cohort with plastic. And the phthalate exposure explained half of the ADD assessed at 4 years after a PICU admission. So keep that in mind. This is one of those reasons this is one of those facts that for a variety of reasons, it's so important to de-escalate patients. Taking out lines, tubes, and drains early not only minimizes the plastic exposure, but also decreases the amount of fentanyl and Versed and other things that we give kids to keep them comfortable. So all of this is interrelated. Let's talk about the ventilator. Consistently, if you're intubated going into the OR, you have worse long outcomes. Well, that could be because you're sicker, but it could also be related to other things related to mechanical ventilation per se. And as we know, we talked about length of stay. The strongest predictor to CICU and hospital length of stay is the duration of mechanical ventilation. So how much ventilation is too much? Well, there's ways we can measure this and write papers, and then there's the variability that happens day to day in the unit. I don't know if you have had a chance to sit back and watch suctioning in a relatively stable patient. It's a good time for the RN and the respiratory therapist to catch up on things when the patient's stable. And it's not uncommon to see the bagging rate at about 40 or more per minute, at least in units that I've worked in and observed. So there are transient periods of hyperventilation that occur with suctioning or agitation or other things like that, that may actually play a role that we can't measure when we do retrospective chart reviews. This is a good friend. I don't know if Jeff's on the line. Jeff and I worked together for about 15 years in Philadelphia. He is a glorified nerd. I love this picture of him with those 3 old laptops. And he entered with a medical student every single blood gas and every end-tidal CO2 that he could find, but it was mostly the blood gases and the vital signs on 99 children with hypoplastic left heart syndrome. This was published in the Artificial Intelligence in Medicine because we used Bis Samata and Nat Nataraj, who were the first senior authors from Villanova, used a very high level of artificial intelligence and a lot of statistical features that I would have no idea how to do. And they did these node analyses, and to greatly simplify it, that the combination of diastolic hypotension and hyperventilation was 100% predictive of periventricular leukomalacia in this group of patients. So the combination of a low diastolic pressure and a low CO2, decreasing cerebral blood flow and a low diastolic pressure, affects in particular the white matter of the brain. All right, so now we get a group of really bright Canadian cardiologists who are following these patients in the hospital and then at home. And now you can see the time of that operating time. So this is a transposition. The time from the ICU is minor compared to time that the baby and the family stay with this cumulative exposure to stress, plastic, et cetera. So first and foremost, the most modifiable perioperative factor for improving long-term outcomes, which you can start right away, is a concerted effort to reduce hospital stay and measuring the factors that worked for you and then sharing that with the rest of your cohorts around the country. We do know longer length of stay is associated with the things we just talked about, but what I haven't spoken about yet is about worse parental, mostly maternal mental health. We all know that the most common complication of pregnancy is maternal depression. And if you put maternal depression together with a baby on a ventilator, loud noises, no sleep, poor food, and fear, constant fear, it's really hard to imagine that any of these moms make it out of there doing well. It just amazes me, the strength of these parents. And it's usually, I'm generalizing, of course, but it's usually the mom. So now we put that first year of infancy down there, and talking about the difference of anesthetic exposure and fentanyl and Versed, all of that from a time perspective pales in comparison to what it's like to care for a kid with complex heart disease. So we know that it's not cardiopulmonary bypass as the factors here. It may account for 5% of the variance. It's preoperative risk factors that we've talked about, postoperative risk factors, long length of stay, and how can we help in that really vulnerable period after a baby in particular gets an operation. Remember, these moms have never been home. They went right from delivering a baby right to the hospital. Infants, they've set up a support network, and children, but this is very, very different. And this has been studied by Frank Casey and the group in Belfast. And when you look at the variance of scores that say surgery only accounts for 5%, maternal stress and anxiety or parental mental health accounts for 6 times that variation in score. And again, if we had to decide where to put our resources, if I had to pick one thing that's not only the right thing to do, but probably would have the biggest benefit, it'd be to start right away in things that help the families. These are the particular things that were studied by George McCusker, Frank Casey, and others, which is maternal worry, maternal mental health in general, and then if the child has any visual perceptual challenges or visual motor integration, which translate to handwriting. So now I'm going to ask you, what are you doing about it? What are you doing about the black box in your unit now that you know that there are things that we can change? So I just want to share for the last 10 minutes of this presentation the joy that I have to have come to Children's National in the last 3 years and start working with a group of incredibly dedicated and passionate people about the brain and congenital heart disease. It starts in the fetus, and Audrey Duplessis is a neurologist that I worked with in Boston 30 years ago, and Kathy Limperopoulos has done some of the most seminal work in the decrease of cerebral blood flow in kids with congenital heart disease. And there are a number of potential research arms here now that we've identified that what can we do about it, detecting fetal heart disease. Similar work's being done by Mike Seed and the group in Toronto. And what I love about 2020 compared to 1990 is we all share our information freely. We're going to hopefully move that into the intensive care unit, look at connectivity, things along those lines. In the operating room, Richard Jonas has a long track record of interest in the brain, and Nobu Ishibashi. We've been funded now to do the first, we're in a phase 1 clinical trial, delivering mesenchymal stromal cells to the brain through the arterial limb of cardiopulmonary bypass. So we can give these stromal cells directly to the brain. And we've enrolled 1 patient, and we're just starting to look through that now. And then I'm going to share the final part is the NeuroCardiac critical care program that I mentioned before. First and foremost, it takes a village. Melissa and my colleague Cheryl Caprarola in the cardiac ICU sort of coordinate a group of therapists and nutritionists and social workers and dietitians. And we'd be nowhere without the great neurology that we get from Dr. Carpenter, Dr. Harar, and Katie and Meredith, the 2 nurse practitioners. It's a huge group dedicated to improving things for these kids. And our goal is to optimize, or our vision at the institution is to optimize long-term development. And we're trying to eliminate brain injury in the CICU, just eliminate it. I have a big, hairy goal here. We've developed a proactive strategy that includes state-of-the-art neuromonitoring and neuroprotective strategies, measuring and maximizing cerebral oxygen delivery, evaluating and treating mental health, as well as identifying those patients most at risk. At most intensive care units, the neurologists are called reactively to a hemiparesis or a seizure or something like that, but ours are actively involved in patient care. For neonates at high risk for neurodevelopmental disorders, again, this is from the scientific statement. We have our dedicated staff and dedicated monitoring, and we've integrated cardiac and neuro monitoring. And we're moving forward with all of this. And I'll come to the questionnaires and outpatient visits in just a second. This is the group that in the literature has been determined to be the most at risk for neurodevelopmental disabilities. So neonates and infants, additional abnormalities, obviously ECMO or CPR, neurologic or genetic syndromes, and then a prolonged length of stay. And there's a lot of overlap between these groups. I want to thank Melissa. I don't know if she's on the call, but I want to thank her and the group publicly for all the work that they do on a daily and then weekly basis, rounding on these babies. Like I said, this is a team sport to look after these kids. I just want to check my time here. Okay, they have shared with me the 4 B's of nursing, and this is going to be recorded, I believe. So it's the brain for neurogenesis, the body, bonding with mom, and breast and bottle feeding. This will show up on the recording, I'm sure. I'm not going to go into Melissa color-coded Excel spreadsheet, but we use this a lot. And then we have the 5 pillars of care, which are standardized assessments, monitoring and surveillance, neuroprotection trials, neurodevelopment, and extended family support. So to summarize then, there needs to be further research on timing of surgery and the effects on anesthesia. I think right now we can shorten the duration of ventilation and avoid hyperventilation, reduce length of stay, give family support in and after the CICU, and then turn them over to an outpatient follow-up team that's been in place for, 11 years now in Children's National, run by Jackie Sands and Mary D'Onofrio, as well as who we've talked about before. Okay, with that, I'd like to close and answer any questions. I think I had a picture I wanted to show you. There's Audrey and Jane and Amy. I already showed that. I apologize. That's in there twice. Constantly think about this when you get back to work. What are you doing about it? It was such an amazing event in my year. I stay in touch with a lot of the families of my patients. This is Nico, and I called Nico's dad and said, can I present pictures of Nico at the Canadian conference? So he sent me this picture, and he showed that to Nico, who sent me this picture because he's now 10. And I'm glad that I can have this type of impact on my patients as they get older. There's David. There's David 29 years later holding his kid. And I'll close with saying neuroprotection is absolutely mandatory. Thank you all very much for your time, and again for the honor of participating in this course in general, but also giving the Peter Ali lecture in particular.
Thank you very much, Dr. Wernovsky. It was absolutely a great breadth to your presentation, great overview, and really bringing up some important points to highlight to us. So I'm looking basically at the question and answers that people have been asking. A lot of questions about what are the neuromonitoring tools that are used in the intensive care for the patients in post-op cardiac surgery.
Yeah, that's a very appropriate and timely question. I've been having this discussion with Dana and Jessica in our neurology, as well as with the rest of our whole team. So let's start with NIRS. To my knowledge, NIRS has been widely adopted, almost universally adopted, with little predictive validity for long-term outcomes that I know of. That doesn't mean we shouldn't be using it, because for me at the bedside, it does help me as not a surrogate, additional clinical marker for how a patient is doing. Because most times, as you know, we're dealing with internally inconsistent information. This is high, this is low, this is good, this is bad. NIRS adds to that decision-making tree. So I find good in the short term, no predictive validity. Next, for long-term outcomes. Next would be, what else could we talk? EEG, all right? So EEG is now routinely used in our patients and in many other centers for 12 to 24 to 48 hours after surgery. They're very good at predicting subclinical seizures. It turns out, actually, that I've read a couple papers recently that preoperative newborns are having subclinical seizures too with congenital heart disease. We think that if there are seizures, it's right to treat them to prevent further metabolic loss in the brain. I just reviewed with Dr. Harar our current data, and although it's reported in the literature to be about 10% risk of subclinical seizures in large cohorts, that's not been the case in our unit. It's been down to about 1%. So we're going to be rethinking and hopefully publishing soon the routine use of EEG at the bedside. We've also moved very recently to an automated EEG that the bedside nurses are being trained in if they have a suspicious activity there. There's not much else, there's MRI imaging, which many centers are doing before and after surgery. Other things in terms of monitoring, like a BIS monitor, I don't know if that's been utilized yet in terms of helping you determine if you can lighten up your sedation. I hope I got most of them. Were there any other things you could think of?
Well, people have been asking about transcranial ultrasound to study blood flow. Is that something that you've heard people looking at?
I've heard it on a research basis, not on a continuous probe. And I'd love. There's not only so much real estate on a baby's head. Mm-hmm. And, you want to figure out if you want to put on a NIRS probe and an EEG montage and a blood flow. There's nothing there. And it turns out one of the most common reasons that parents have withdrawn from some of the neurodevelopmental studies I've been in is they don't like the way the EEG looks, which I would never have thought, right? There's a sternotomy in a tube, and all this other stuff, but I think that's most of them.
Perfect. Another question that's coming up is any delirium. Is that something you guys follow in your patients in the intensive care?
We generally follow it in our staff first. And, with all the new scores, it's a common term for our staff to be using. And with the CAPD scores, we're able to sort of put a quantitative number on it. I don't think, this is no data, this is just an opinion. I don't think there's a really good way to measure it in neonates and infants. But it's a pretty good thing for children and older children. So we're measuring those scores. We're trying to get an assessment. We haven't done any research trials yet in terms of Seroquel or a variety of other medications that may work. I think most places will say, try to normalize the day for the kids and day and night cycling and teaching plans and things like that.
Interesting. I'm going to ask you a question. In our follow-up clinic, we do see about the same amount of PTSD. What's amazing is that it's not the sickest children whose parents have a PTSD. It's a real spectrum. Mm-hmm. Is there something we can do to help out these families of less sick? Are we minimizing the illness and that leads to that reaction?
I think we make, and I do the same thing. I think we make an association between what we think is bad and what another family might think is bad. And we're not in their shoes, right? I always have said that some of the most stressed out families in the ICU are parents of a child with an atrial septal defect. And when you think about it, they had a healthy kid that all of a sudden was told they needed an operation or they were going to die early. And they come in and usually they're doubled, and usually the medical staff pays much less attention to them. And when I put it in that context, it kind of makes sense to me that the ASD family is ASD's family. The child with an ASD's parents may be more stressed out. So that's a very good and important observation. I would think we all need it. It's not just the parents, right? We work in a tough environment. Bad things happen. There's ego and other problems that go on. We all need support. One
of the questions was, are there any repairs we just shouldn't be embarking on if the goal is neurodevelopmental priority? Wow,
I didn't think we'd go there. I had a debate in London and with a guy named Danielle CD about whether we should operate on kids with hypoplastic left heart syndrome. And I know Annie and others, and we've talked a lot about this. And And we were debating back and forth, and somebody raised their hand from the back and said, have you asked the children what they think about that question? And, you know, we can't lose sight of the fact that, or at least this is just Gil's opinion. We can't lose sight of the fact that what might be a good outcome, a bad outcome for one family is a good outcome for another patient and family. I think we have to be rigorously honest with the families about what to expect. That for sure. Then the decision becomes the families. But it's not about the repair. It's not like one group of patients versus another group of patients.
Very interesting.
I wish this was live, because then we could have some banter back and forth. And
yeah, it's only live with the moderators, not with the. There are 240 participants, which is amazing. Also, I just wanted to mention.
Congratulations on your first one. That's fantastic.
And just to let you know, there are 12 separate questions for your presentation. So obviously, there was a lot of interest in what in what you were talking in your talk. But
I can answer them after. You'd like me to answer them offline? I'm happy
offline,
to.
but there's one that maybe we could end with. Is there such thing as a neuroprotective bundle for the cardiac intensive care, and in terms of long-term neurodevelopmental follow-up bundle? Or those, I guess these are the.
Let me tackle the second one first. So I'm a member of the Cardiac Neurodevelopmental Outcome Collaborative, and we have just had our manuscript accepted for the birth to 5-year recommended strategy. So that will include questionnaires over the first 3 years and direct examinations, and I may be getting this wrong, but at 12 months, 18 months, and 36 months, and 60 months. So that's the long-term follow-ups. There will be recommended things, and then you have to balance time. And it was a great thing that Ben said at the beginning. There's also distance, right? And the reality is, in Washington, we can get it done face-to-face, but with telemedicine now, it's doable, or at least possibly doable. Melissa, Melissa Jones, has been working with a large group of people trying to see what that bundle might be. There's a bundle now to try to reduce or try to increase non-pharmacological sedation. So that's bundling, constraint, those sorts of things. We are working on a sedation protocol. So we, again, we can't sort of not give half the kids the treatment. So it's going to be really hard to know what the effect is, but we should have that bundle of early mobilization, parental support, reducing sedation and benzos, reducing noise. We should have that published relatively soon. And my email is Wernovsky@childrensnational.org. And if anybody, and I'll put that in the chat. And if anybody wants to discuss things they've done, I'd love to hear. We love to share other people's best practices. What is it? Share seamlessly, steal shamelessly. That's from the NPCQ, I see. So the more we share the stuff, the better.
Thank you so very much. It was honestly a great talk to start off. I mean, we're starting off really with the ending. It's the outcome that counts, and that's a way for us to have the right vision for this talk and for our care as clinicians. So I really want to thank you very much.
It's been an honor. Thank you very much, Baruch, and your colleagues for inviting me.
Great. I think we're going to go to the next section. And the moderator for this next section is, his office is about 20 feet from mine. His Guillaume Emerio, who's a pediatric intensivist with us, who has completed his training in France and in Montreal. And he's a senior scientist of the Fonds de Recherche du Québec de la Santé. And his research interests are on patient ventilator interactions, synchrony, respiratory monitoring, neuromonitoring. And he was involved in the International Consensus Conference on pediatric critical care transfusion and anemia expertise, otherwise known as TAXI. So we thought he would be the right person to moderate a session on transfusions. Guillaume.
Thank you, Baruch, and welcome everybody. And it's a pleasure to introduce and moderate this session about transfusion after pediatric cardiac surgery, which in particular aims to review and debate about these recommendations that came out from TAXI, this conference that took place 2 years ago. This session will be based on 3 15-minute conferences, and we'll have 10 minutes for questions at the end of the talk. So please use the Q&A tool and be patient. We'll address the questions at the end of the three sessions. So just to leave as much time as possible for the presentation and the questions, I would like to introduce now with pleasure Dr. Steven Schwartz, one of the co-organizers of this conference, and who we will give the first talk. Dr. Schwartz is a professor at the Department of Critical Care Medicine and Pediatrics at the University of Toronto. He's the head of the Division of Cardiac Critical Care Medicine and chief of the Department of Critical Care Medicine at the Hospital for Sick Children at Toronto. And he will give us the first talk of this session and presenting the TAXI results. So thank you, Dr. Schwartz.
Thanks, Guillaume. So Shailin, if I can take this screen, there we go. There we go. Does everybody see my slides?
Yep.
Great. So I was asked to sort of set the groundwork for the debate that will happen between David Ferroni and Dominic Cave by going over the TAXI recommendations that were put out a couple of years ago. I don't have any financial disclosures. One disclosure is that I was one of the co-authors of the cardiac section. And I will say up front, I'm not going to editorialize about this. I'm going to lay this out and let David and Dominic take care of the editorializing. But we went into trying to come up with recommendations, recognizing that there are reasons to transfuse patients in the cardiac ICU and reasons to avoid transfusion. The reason why would we transfuse our patients? Well, red blood cells improve oxygen carrying capacity and oxygen delivery, presumably. Transfusion can improve saturation in cyanotic patients, which gets back to, again, oxygen delivery. We want to prevent organ damage, including brain damage, as Gil just talked about, prevent cardiac arrest in vulnerable populations, such as those with poor ventricular function, pulmonary hypertension, or single ventricle patients. And in some places, and certainly at places I've worked over the years, we used to and sometimes still do transfuse people because we like a specific hemoglobin number. But why wouldn't we transfuse? Well, there are a number of studies, as I'm sure you're all aware, suggesting that transfusion does not improve or may even worsen outcome in multiple populations. There are infectious risks related to transfusion. There are religious reasons. Some people are not easy candidates for transfusion, at least. And transfusion is expensive and is a waste of resources if patients don't need it. So this is the paper that was published in Pediatric Critical Care Medicine as part of a larger series of recommendations on transfusion in critically ill children in general. Our group, led by Jill Chillette from Rochester, Ariane Willems, Stacy Valentine, Scott Bateman, Stacy and Scott led the entire TAXI initiative, and myself put together recommendations on red blood cell transfusions for infants and children with acquired and congenital heart disease. I'm just going to kind of go through the paper a little bit. In the introduction, we sort of have a disclaimer. We recognized that there was a paucity of high quality data exploring transfusion thresholds in many of the subpopulations in children with cardiac disease, and in fact, in children with cardiac disease overall. When you look at the transfusion studies that have been done, children with heart disease have generally been excluded from virtually all of them, except for a few specific ones that have focused on these children. So we really don't have a lot of evidence to base these recommendations on. And so that gets to the second bullet point here, that there's generally a low level of evidence for most of these recommendations. The recommendations are, as it says in the article, intended to initiate discussion and identify research priorities regarding transfusion management in these very complex patients. So the key point here is this is not gospel. So I will not be offended should either of the next two speakers disagree with any of the recommendations. I will state up front, I don't always follow all of these recommendations. The way that these recommendations came into being, the way that a lot of these things do, the process was a large data search going back to 1980, updated through May 2017, which was when we put essentially pen to paper for the final recommendations. We identified additional references from the articles that were searched. Two authors reviewed all of the citations independently. There was the usual evidence grading system. The entire TAXI group consisted of 38 experts from 29 institutions in 8 countries. I know some of you are on this call or on this webinar. We met 3 times over 2 years to develop evidence-based, and when evidence was lacking, expert-based recommendations for red cell transfusion in a whole bunch of different groups of critically ill children. Jill, Ariane, and I primarily coordinated the cardiac disease subgroup, and the recommendations were developed and supporting literature reviewed and scored by all of the panel members, so all 38 members, using the research and development UCLA appropriateness method. And to end up in the final recommendations, that group of 38 people needed at least 80% agreement. So what did we say? Well, started with good practice statements. In children with cardiac disease, we recommend optimization of all of the components contributing to oxygen delivery, including but not limited to achievement, maintenance of normal sinus rhythm and or heart rate control, optimal preload and contractility, optimal RV and LV afterload, adequate oxygenation and or reduction of oxygen demand as appropriate before initiation of RBC transfusion, except in the case of hemorrhagic shock. So bottom line is fix what you can fix. That doesn't involve transfusion unless they're bleeding, in which case, of course, part of the problem is that they need blood. We recommended that for all children with congenital and acquired heart disease, the benefits and risks of transfusion are considered before transfusion. Wherever possible, adoption of blood sparing and conservation procedures and guidelines should be implemented. So in other words, again, transfusion isn't the first thing you do, it's more toward the last thing that you do. In children undergoing cardiac surgery or heart transplants, when deciding to transfuse, we recommend considering not only the hemoglobin concentration, but the overall clinical context and risks and benefits. So again, consistent with the idea that we don't transfuse specifically to a number, but you fix what you can fix. Obviously, there are some things you can't fix. And when you feel the need to increase oxygen delivery and the hemoglobin is low, that's all you've got left. In infants and children with congenital heart disease, we recommend investigating and treating preoperative anemia, in addition to implementing transfusion and blood management guidelines and blood conservation practices. So this was more at a programmatic level, and I would expect that the next speakers will speak to this a bit. There are a number of blood conservation strategies that have come into being over the past several years. For hemodynamically stable patients with congenital heart disease and good oxygenation for their cardiac lesion, and normal end organ function who are awaiting surgery, we recommend that risks and benefits and alternatives of red cell transfusions must be carefully considered when deciding to give an RBC transfusion. So you get the sense that this is not very dogmatic. When we got to specific subgroups, so myocardial dysfunction, which is considered, a fairly high-risk subgroup in terms of sudden death and sudden hemodynamic decompensation. In children with documented RV or LV myocardial dysfunction, acquired or congenital, there is insufficient evidence to support transfusion to a target specific hemoglobin concentration. Furthermore, there's no evidence that transfusion for a hemoglobin level greater than 10 is beneficial. So you can see this kind of language repeated several times. And the issue is that there, again, aren't clear target hemoglobin concentrations supported by the literature. These lower levels were chosen as a mix of expert consensus or papers that are out there that are essentially small case series where there's at least some evidence that patients with this condition, in this case myocardial dysfunction, were allowed to have hemoglobin levels down to 10 or 100 for those of you who use milligrams per deciliter, where they were allowed to have hemoglobin levels that low and did not seem to suffer adverse events, but that's very different than an actual transfusion trial. Pulmonary hypertension, another high-risk group, same sort of thing. So in children with pulmonary hypertension, using standard definitions, insufficient evidence to support transfusion to a target-specific hemoglobin, and no evidence that transfusion for a hemoglobin level that's already above 10 is beneficial. Preoperative uncorrected congenital heart disease in general, we recommended transfusion to maintain a hemoglobin concentration of at least 7 to 9, depending on the degree of cardiopulmonary reserve. There's obviously a lot of leeway in that recommendation. Even with that, it was weak with low quality evidence and just barely passed the 80% threshold of agreement. Intraoperative management. In infants and children undergoing cardiac surgery, we recommend development and adoption of intra and postoperative blood sparing and blood conservation procedures and guidelines with the goal of reducing the number and volume of RBCs transfused and limiting donor exposures and other blood component transfusions. Everybody agreed that you should do this. And again, there are a number of techniques. I expect they'll be brought up in the subsequent talk. Some of the biggest debate was around the stage 1 type single ventricle palliation infants, in infants undergoing these procedures of any type who have stable hemodynamics, adequate oxygenation for their cardiac lesion, and normal end organ function. We recommend avoiding reflexive, solely hemoglobin based, in other words, red cell transfusion if the hemoglobin concentration is greater than 9. So that's a way of saying that once it gets below 9 or 90, we would generally recommend transfusion. Again, this is a weak recommendation and mostly based on Jill Cholette's one paper where they did have a liberal versus a conservative hemoglobin strategy in this population of patients. And there were at least some patients whose hemoglobins got down to 9 and didn't have adverse outcomes, but there were patients randomized to the conservative approach who were transfused before their hemoglobin got to 9 for other reasons. So it wouldn't be unusual in this population before the hemoglobin reaches that level to find other indications that support transfusion. For stage 2 and 3 palliations of single ventricle patients, so Glenn and Fontaine circulations, we recommended not administering a red cell transfusion, again, if the hemoglobin is greater than 9. Jill's group in Rochester had another paper looking at this, especially in the stage 2 patients. Their primary outcome there was lactate levels, which I'm not so sure is the optimal outcome that you want to look at. But again, the same sort of recommendations. Some patients can get a hemoglobin this low, and if they're not prohibitively cyanotic, you wouldn't necessarily recommend transfusing them. For biventricular repairs, for patients who are hemodynamically stable and have adequate oxygenation and normal end organ function, we recommended allowing the hemoglobin to go down to 7. Again, there was 100% agreement on that. And there was considered moderate evidence for that. We addressed the issue of storage duration. There were a number of papers that had come out around this time, including several from here in Toronto, looking at the age of stored red cells that are transfused in these patients. We concluded after looking at the literature that standard issue transfusions should be utilized in children with acquired or congenital heart disease, as there are insufficient data supporting transfusion of red cells of shortened storage duration in this population. Again, that was relatively weak. The evidence does go in both directions, but it's not particularly strong. I'm going to end and let those who are going to have more opinionated talks take it from here, but I'm going to finish with what I call a story with no moral. And in other words, this is something that actually happened. I still don't know what to conclude from it. A real patient, 6-month-old Jehovah's Witness with tetralogy of Fallot, who's now post-op day 1 after repair, has had a good anatomic repair, no residual lesions, has modest but not terrible restrictive physiology, seems to need a CVP around 12 to maintain good cardiac output. The baby's had junctional tachycardia on and off overnight with a variable mixed venous saturation, variable lactate and urine output. Now on post-op day 1, the heart rate is 155. We are AAI pacing, but there are bursts of jet that are coming through. The blood pressure is, even in the AAI pacing, is 58/30, so a bit low. Saturation is 90%, and the child is cool peripherally. Blood gas shows a pH of 7.4, CO2 of 58, mixed venous sat of 38%, a lactate of 5.2, which is increasing, and the hemoglobin is 74. I admit that I wanted to transfuse this patient. I had a long discussion with the surgeon who had promised the parents we would do everything to avoid transfusion. We settled on a compromise. We agreed to wait 1 hour for transfusion and to try to do a couple of other things. We started vasopressin to bring the blood pressure up and gave a small bolus of amiodarone. We improved the ventilation. 1 hour later, the blood gas was a bit better, pH 734, CO2 42, mixed venous sat 54. Recognized that's still a wide AVO2 difference, and the lactate had come down to 2.8. The patient continued to recover over the next few days without transfusion and no acute issues, did not have a cardiac arrest, did not have renal failure or anything like that. The patient stayed in the ICU for 5 days. I will tell you that that is a very long time for a post-op tetralogy patient with no residual lesions in our unit. You just heard from Gil in the previous talk about all of the bad things that can happen to your brain when you hang around in the ICU in the hospital for a long time. I know that we avoided transfusion in this patient. I do not know if we did this patient any favors. And so that's why I call it a story with no moral. Perhaps David and Dominic will have better insight to tell us what we should have done here, recognizing it would have taken a court order to give the transfusion. But with that, I'll just conclude by saying, in my opinion, what should we do? It's somewhere, or based on these recommendations, it's somewhere between unnecessary and a bad idea to transfuse pediatric cardiac patients based only on hemoglobin without other patient-specific indications. Evidence of low oxygen delivery based on exam, vitals, mixed venous set, lactate, and or end organ function combined with a low hemoglobin is reason to strongly consider transfusion. Assessment of risk of cardiac arrest or end organ injury, such as neck, for high-risk groups with poor ventricular function, shunted single ventricle physiology, severe pulmonary hypertension, etc., is highly subjective but not unimportant. And randomized studies are hard to do for a number of reasons, but inherent practice variation between programs may be helpful. And as we all look, we'll talk tomorrow about quality databases and things like that. As we all look at our accumulated practice data, we may get some insight without the kinds of trials that we found it so hard to do. So with that, I'll end. I will turn my screen back over to Guillaume, and we can move on to the next speakers. Thank you.
Thank you for this nice presentation, and this nicely set up the stage for the rest of the discussion. For the second talk, we are happy to welcome Dr. David Farani, also from the Sick Kids Toronto. Dr. Farani is a pediatric anesthesiologist and a PhD, originally from Belgium, and now a staff anesthesiologist in the Division of Cardiac Anesthesia at the Sick Kids. Associate Professor of Anesthesia and in the Department of Anesthesiology and Pain Medicine at the University of Toronto, and Associated Scientist in the Department of Translational Medicine at the Sick Kids Research Institute, Chair of the Research Committee for the Congenital Cardiac Anesthesia Society. And they will explain us why we should follow the taxi recommendation.
Thank you, Guillaume. And thank you for inviting me. It's a really honor to be with all of you guys as a cardiac anesthesiologist. As Guillaume said, I'm an anesthesiologist, not an intensivist. And my job today is to try to convince you that what Steve showed you as a recommendation from the taxi should be followed. I don't have any financial conflict of interest, but I'm involved in a few scientific societies, 2 of them being clearly around promoting patient blood management. So you clearly understand that my opinion will be towards restrictive transfusion. So the objectives are, first, I'm not going to review the recommendations because Steve just did that. I'm going to briefly discuss restrictive versus liberal, and I won't spend too much time on it because I think it's a story of the past. But what I'm going to try to do is to convince you that there's no need for a debate here, because we all understand the risk of blood transfusion. We all understand the benefits of blood conservation. And even if the pediatric literature is weak, and it's usually always weaker than what you find in the adult world, poor evidence is not an argument that we should use. And finally, I'm trying to tell you a little bit about the patient-centered approach versus the one-size-fits-all, which actually has been the future for a long time, but we're still talking about in our daily practice. So we can't talk about transfusion in pediatric patients without talking about Jacques Lacroix studies published in 2007 in the New England Journal of Medicine, prospective randomized study looking at pediatric intensive care patients and comparing a restrictive transfusion strategy with an hemoglobin of 7 as a trigger and a liberal transfusion strategy with a hemoglobin of 9.5 as a trigger. Results that I'm sure everybody knows on this Zoom, the use of a liberal transfusion strategy significantly increase the number of patients being transfused in the intensive care without any difference in terms of organ dysfunctions of 20 or 20-day mortality. So the evidence from this study is pretty clear that whether those numbers are right or wrong, the restrictive transfusion is not inferior to a liberal transfusion strategy, so more is not always better. This is a sub-analysis of the study published by Ariane Willems a few years later that actually focused on the cardiac population. And you can see pretty much the same thing here, the same threshold for a transfusion, of course, because it's a sub-analysis. And the results here showing you that basically patients that were treated with a liberal transfusion strategy were exposed to significantly more to transfusion without any difference in terms of organ dysfunction and mortality. So even in a subgroup of cardiac patients, the use of a restrictive transfusion strategy was not inferior to a liberal one. Steve mentioned those two studies, which basically are, as far as I know, the two only prospective randomized study that actually looked at specifically at patients with cardiac disease. This is the first study on single ventricle physiology, so cyanotic patients that were randomized to be treated either using a restrictive transfusion strategy, so with an hemoglobin of 9 as a target, as a trigger, and a liberal transfusion strategy with an hemoglobin above or equal to 13. The study, even though was small, shows that the children with single ventricle physiology did not benefit from a liberal transfusion strategy after cavo-pulmonary connection, and therefore should not be treated liberally. As you can see here, the restrictive transfusion strategy was significantly decreased the number of transfusion donor exposures and also potential risks associated with transfusion. As always in those studies, larger studies are needed. We haven't seen them yet, but of course, this is something that we have to take into account. On the right-hand side, you see the outcome of a pretty similar design in patients that underwent BIV repair or palliative procedures with pretty similar transfusion threshold compared to the other studies I showed you, with again, no evidence that the liberal transfusion strategy was any better. So in terms of restrictive versus liberal, it's not really a topic that I really like. And I hope that in the future, we won't see any more of those restrictive versus liberal, because it doesn't really answer the question that we have to ask ourselves on a daily basis. So I don't think the decision should be based on a single magic number, but more based on physiology and pathophysiology, and also on the dynamic process in our patient. Patients that are bleeding are different than patients that are pretty stable, extubated and ready to go to the ward. So using a single magic number is not really helping us. But what I would say is whether we transfuse those patients or not, we should always have a conservative approach. and transfusion to reach a number in a patient that is completely stable does not make sense and has never been shown to be better. And why should we be conservative is because transfusion is safer than ever, but transfusion is still associated with a significant number of complications. I, in my life, have never seen an infection related to transfusion, but I do have seen transfusion-related acute lung injury. I do have seen transfusion-associated allergic reactions and also TACO. So those complications, even though are pretty rare, are still complications that we see pretty frequently in our intensive care. This was a report pretty old now from 2007 in Quebec, showing you the incidence of the different complications. And you see that it's a pretty significant number with minor allergic reaction and febrile non-hemolytic transfusion reaction in the top here, and also the number of errors associated with transfusion that we've seen, I'm sure, in all institutions. So transfusion is better than it used to be, but it's still associated with a significant number of complications. When it comes to patients that are like our patients or cardiac patients coming for multiple procedures, the risk of transfusing them over and over will increase the risk of alloimmunization. And it's not from cardiac patients, but if you look at the sickle cell population, you will find that the risk of alloimmunization in patients that are transfused over and over is somewhere around 25 to 47%, which is a significant proportion of the patient, which will sometimes make it difficult to find products or suitable organs. This is an example from 2018, looking at patients undergoing heart transplant, and you see that the patients who did receive transfusion before the transplant did worse than the others, with a significant here after adjustment for other confounding factor association between transfusion and outcome. The more you transfuse, the worse it gets. And this is a study that we did a few years ago in pediatric patients, but non-cardiac patients. And you can see that as soon as you transfuse more than 20 ml per kilo, which basically is more than one episode of transfusion, the 30-day mortality in those pediatric patients being transfused compared to a matched cohort, so with the same comorbidities and undergoing the same type of procedures, but who did not get any transfusion, significantly increased. And it's clear that one of the thing you can say about that is the mortality increasing because of the reason you are transfusing or because of the transfusion? And I would say it's probably because of the combination of both. Nobody gets 60 ml per kilo if they don't need it. But at the same time, you can see clearly that even after adjusting for confounding factors, the transfusion is increasing the risk of mortality significantly. And it's not only mortality, but infection here, as you can see on this part of the slides, shows that as soon as you transfuse more than 20 ml per kilo, you significantly increase the risk of postoperative infections. And I was a bit more lazy than Gil was because I didn't show that many of those studies, but there are a lot of studies in the literature, mostly retrospective, that actually shows that there is a clear association between blood transfusion and bad outcome in pediatric cardiac patients. And I don't want to go through all of them, but really, if you look at the literature, it's pretty clear that the more you transfuse your patients, the more you increase your risk of postoperative complications. That being said, we have to think about the risk factors. We have to think about why are we transfusing. This is very important, and it's a no-brainer, and I'm going to tell you in another slides that if the patient is bleeding, you have to transfuse because transfusion will save your life. But you have to think about when and why you're transfusing, how much and how many different blood products are you going to give, and also to which patient. And we all know that patient's comorbidity will have an impact as well on the effect of the transfusion. Two things that I will discuss in the next couple of slides. One will be anemia, and the other will be bleeding. So in terms of anemia, we all have waiting lists. And I don't know across the country what the waiting list is for you guys in terms of cardiac patients, but I can tell you that for non-elective cardiac patients, our waiting list is relatively long and can be months. And there are a few studies, and two of them that we did here a few years ago, one in neonates, one in non-neonates pediatric patients, non-cardiac again, showing you that patients with anemia are doing worse than patients without anemia. And if you look on the right-hand side here, it's clear that the transfusion in the patients who were not anemic, but were transfused, and the patients who were anemic and were transfused, you see that the risk is increasing more and more when the combination of both is present. So I think in 2020, and with the programs that we have across the country, it's almost unethical to bring a patient with anemia to the operating room if you have time to optimize. This is an example from Johns Hopkins. This is a good friend of mine who presented that study a year ago at the CCS meeting in the Bahamas, who pretty much shows you that the patients with the cardiac patients this time who went for surgery with cardiopulmonary bypass with preoperative anemia had an increased risk of complications, including length of stay, which, as we heard before, is a significant problem. We at Sick Kids are pretty lucky to have a pre-op anemia clinic. I'm hoping that in the next couple of months, we'll have results with data to show that those patients who are seen in the anemia clinic, who are treated with iron therapy while they are on the waiting list, are actually doing better than those who are not. So there are many and more patient blood management or blood conservation guidelines. This is one example, again, with Jill Shollet that we published 2 years ago. And there are many things that we can do to improve the way we transfuse intra-op, but also post-operatively. And I'm not going to go through all those aspects because of time, but really treating the patients and optimizing the patients before surgery is an important part of our strategy. And as I said before, having a blood conservation program with restrictive or conservative transfusion strategy is the way to go in 2020. As I said, blood transfusion might be bad for you, but this is not if you're bleeding. So there, in our cardiac patients, I find 3 different categories or 3 different aspects that we have to take into account. The bleeding patient needs to be transfused, and we're not going to debate that because I think we all agree on that. The patient with preoperative anemia and iron deficiency need to be treated, and transfusion is not the treatment. Iron supplementation is the treatment. So those patients on the waiting list need to be treated for their anemia before they come to your OR. And then you have this gray zone, as always, where we have to think about why we are transfusing. Not every patient will benefit from transfusion, and you have to think about why you're transfusing, which patient, and how much. And I think I grew up in Belgium, as Guillaume said, and I trained with this guy here that I think nobody needs to be introduced to. Jean-Louis Vincent is a well-known adult intensivist, and I grew up with him in early 2000 when we were talking about goal-directed therapy and early goal-directed therapy for sepsis management. And I find transfusion is the same way. You have to think the same way. You have to think about what is the indication for transfusion. Is your patient bleeding? No, you might not need transfusion then. Is your patient hemodynamically unstable or has impaired DO2, oxygen delivery? Maybe in that case, you have to transfuse. How much do you have to transfuse? And we've seen those publications on choosing wisely. And I think 10 to 15 milliliter per kilo is a good start. And then you have to wait and repeat and assess what you're doing with your transfusion before you decide if you need more or not. So really, those aspects are very important when you decide to transfuse. So just in conclusion, I think the liberal versus restrictive should not be debated anymore because we have enough evidence to say that the use of a liberal transfusion strategy is not better. And we should not be looking at a single magic number. We should think about why we are transfusing because transfusion is not free of side effect. And finally, blood conservation is important, but it's not all about transfusing. It's also about how can you modify the risk factors in order to decrease transfusion and how to have a patient-centered approach in our patients. So in summary, yes, we should follow the TAXI recommendation. Thank you very much.
Thank you, David. It was very clear and a great overview. We'll now invite Dr. Dominique Cave for the third part of this session. Dominique Cave is originally from the UK and then trained in Canada, in Edmonton, as a pediatric cardiac anesthesiologist and a pediatric critical care specialist. And he joined the pediatric cardiac anesthesia team at Stollery in 2010 as a pediatric cardiac anesthesiologist and a pediatric cardiac intensivist, and is a medical director of that unit. And he will explain us why we do not follow the TAXI recommendations. Dominic.
Thank you. Thank you. I'm going to just share my screen here. And oh, you're still sharing, so I can't yet. Let's try again. Share screen. That one. Share it. And
Yeah.
Great. Very nicely. That's great. Well, thank you, David. That was really depressingly professional, and I'm going to be slightly less so. Well done. I'm going to tell you, everybody else, why you can ignore what the nice man just said, because I think intensivists are quite smart people too. My declarations are basically the kind of things you'd expect. All the images, and there are a lot of them, are under Commons copyright, so I can use those, and some people are going to be a little bit offended. I'm sorry about that. So my problem is that, well, really it's David, isn't it? When it comes down to it, who wouldn't love that face? My job in a pro-con is to poke a few things at him and at the paper, but look at him, who wouldn't trust him? Even I like him. And if I get my point where I'm trying to say something mean about him, who's going to like me? Who's going to be on my side? On the other side of the problem is the paper itself, because I'm only supposed to poke a few little holes in it, because often there's an author in the audience. Hi, Steve. Downside is that, to be honest, to my mind, a lot of this is a dumpster fire, and I'm going to explain why. Fortunately, I don't have any friends, I'm not looking for any friends, and I don't need a job. And I'm English, so I'm probably going to get away with it. What we have is a 22-page document, 21 recommendations, and 93 references. We have a doorstop of a paper, which is broken into 3 pieces: motherhood and apple pie statements, research recommendations, which no one is going to disagree with, and buried in the middle are the clinical recommendations, which is really the kind of poop emoji sandwich that we're going to have to talk about. And that's because these recommendations all come from panel expert stuff. So we need to talk about the panel experts. Really, we all know only 3 of them did most of the work. Again, Steve, thank you very much for the work you put into that. And everybody else kind of followed along. And I'm going to do a little aside here, because I think you need to know one conflict I do have. 20 years is how long I've been a pediatric anesthesiologist. 10 years is how long I've been a pediatric cardiac anesthesiologist. 10 years is how long I've been a pediatric cardiac intensivist. So 7 years of which I was the director of the 2nd largest unit in the program in the country, with outcomes the top 10% of STS and hyperblast mortality under 10%. 100 to 120 is the number of bypass procedures on babies I personally do a year. 500 plus is how many of those kids we admit to our ICU. You getting where I'm coming from? Hundreds of number of liver transplants in adult kids I've done through my 20 years of career, a relatively high bleedy operation. And first is what I am the person in North America to use factor 7A in anger in a child who's bleeding to death. And no one bloody asked my opinion. I am not bitter. It will in no way affect what I say during the rest of this presentation, I promise you. The research bit. I'm in favor, David, keep going. Research is important. I love research. It would be really nice if these recommendations had some. Best practice bit. Also easy to cover. 5 recommendations that everybody would have to agree with. They're wonderful. The problem is we don't live in the Middle Ages or the 1980s where these clothes come from. We live in the 2000s, the 2020s. And the reality is these are not recommendations. These are standards of practice. If you need to read these recommendations in this paper, you should stop reading the paper. Don't take that time. You need that time for something else. You should be calling your lawyer. In fact, I'm going to give everyone 5 seconds right now for anyone who feels they haven't done that yet to call their lawyer. Look at that. We have the same number of participants, which means that everybody agrees with the recommendations. Unlike our experts, you could only get 94% agreement that you should optimize oxygen delivery before red cells. You could only get 92% that you should consider risks and benefits. And if an adequate oxygenation, only 85% of experts thought that was a good idea. Who are these people? A word about the evidence too. It looks like a well-supported paper. There are 93 references. But hidden away on page 3, I noticed in the results section a little line. We should get in close and read this. It says, included randomized controlled trials that form the major evidence base for recommendations are summarized in supplemental digital data supplemental table 1. I think we should look. There it is. That is the entire evidence base for this paper. 4 trials. And the bottom one shouldn't be in there. It's the TRI-PICU study, and I'll explain why I think it should be not there later on. Total N, including that trial, 454. And not a lot of patients to make decisions on that mean life or death. So whilst I'm a big fan of David and the paper, I do think that the evidence tree is looking a little bit shaky. I think we should be careful. And the reason is, the premise of all this is that red blood cell transfusions are bad for you. You know, like voting for Trudeau, or if you live in the West, or a gunshot wound. And I'm not sure we have evidence to support that. The paper tries to provide some evidence. It provides 6 studies, all of which report something negative happening associated with getting blood transfusion after surgery. So let's look at what we mean by that. So here is a nice picture of the sun shining and the grass growing. Grass growing, sun shining. Now it's possible the sun is shining because the grass is growing. Just like it's possible, as study 6 that they offered says, that children who get red blood cell transfusions get NEC 48 hours later because of some tiny, yet to be discovered NEC gremlin that lives in blood and gives you NEC. Or, and I only put this out for completeness as a possibility, or the grass is growing because the sun is shining. And that neonates who have poor oxygen delivery to their tissues because they're anemic get NEC, even if the neonatologist later on remembers to give them red cells. Because sometimes transfusing is not bad. As David pointed out, and I think you'd agree here, in this situation, transfusing is good for you. What matters, as David mentioned, is the risk of blood, the ones we actually know, not these imaginary NEC goblins, real blood risks. Wouldn't it be nice if someone had collected that data for the last 30 or 40 years and could report it to us? Oh, Canadian blood services have. Risk of bacterial infection harm, 1 in 500,000 transfusions. Risk of acute hemolytic transfusion reaction, the most common cause of death. In 2007, 52 deaths in 22.3 million transfusions. What this tells us is to find something that's not a factor 1,000 bigger than these risks, we're going to need quite a lot of patients. We have 454. I'm going to introduce you to the no evidence elephant. The elephant in the room that will present itself throughout this paper where Dominic feels we're lacking some evidence. But before we get to that middle piece, we're going to take 2 recommendations out of the clinical recommendation section because they shouldn't be there. First, the integrative management of congenital heart disease. I agree with everything everybody says. Everybody should make sure you do everything you can pre and intraoperatively to make sure you don't need to transfuse a child. Completely. But that, again, is a motherhood statement. You don't need to pretend there's any special evidence for it, particularly as there isn't. Next, storage duration. Well, I agree there's no convincing data at what age of blood you should use. Some recent large trials in non-cardiac patients suggest that it actually doesn't matter that much, but we don't know. You know what? It should be researched. Get at it. Research is what we're supposed to be doing. Don't call it a clinical recommendation. Which takes us to the 6 things that are clinical recommendations. The first one is the patient with myocardial dysfunction. The evidence presented for this is the PCICU study. Now, that supports a target hemoglobin. Remember, that study excluded all patients who were cardiovascularly unstable and all patients who had no myocardial dysfunction. You know, the group was supposed to be based the evidence on. But we're going to use that evidence and consider it why we shouldn't do something. We have adult RCTs and meta-analysis that are presented in the paper showing that that can be harmful to leave them anemic in heart failure. And Goldberg showed that anemia in heart failure kids is bad. But we're not going to look at that evidence because, because we don't like it very much. That's called confirmation bias. Don't do it, have an elephant. Next, pulmonary hypertensive patients. The authors present the study showing the SVR increases more than PVR. You know, what you want as a critical care physician looking for a PH patient to guarantee right ventricular function, the thing that keeps patients alive with pulmonary hypertension. They also present the study showing anemia is independently associated with worse outcome. And they admit the patients are hypocythemic and hypoxic to start with. But then they recommend not transfusing. Sometimes this is a bit like being an episode of The Walking Dead. You're wandering through the forest and out there are all these zombies going, brain, right? We could use some evidence. We could use some thought in the process. Have an elephant. Preoperative uncorrected congenital heart disease. Again, we fall back on the PCICU study. I like the statement about you giving blood to people who might be cyanotic and have increased hemoglobin needs. But they're saying only do it when you've done everything else. So we're going to paralyze that child and give them myopathy. We're going to pump them full of drugs for a prolonged period of time, exactly the stuff that Gil has been talking about causing harm that we know exists, because they're saying there's no evidence that above hemoglobin above 9 is good for you, and there may be some risks. Well, you've seen the other part of my talk. You know what I'm going to say. I'm going to say, what risks? Show me the risks to that baby to have a hemoglobin of 110. What is the risk? You can't present any, you get an elephant. Next is my hyperplasts. I love hyperplasts. Favorite part of my practice. And here, the authors get a little softer. They're a little more careful because they know people don't agree with them. They recommend no reflex transfusing. Get that. It's fantastic. Concentration greater than 9. Okay. But it's a recommendation based on no evidence. And presenting a study of 162 children's randomized control trial by Jill doesn't actually help, because the number of stage 1 patients in that study is 12. There were 12 hyperplasts in the study, 6 of them in the restricted group, and 2 of those got transfused. So this isn't evidence that it's safe. This isn't evidence that nothing bad happened. This is evidence that you sometimes transfuse hyperplasts and you didn't get enough of them in your study. Have an elephant. Glens and Fontans. So we're using the same study data, really. And this time the number of patients involved is slightly higher. We're up to about 50. So better. But you got to look at the criteria. The criteria required an instability below hemoglobin 9 to transfuse in the restricted group, but didn't below 12.5 in the liberal group. In fact, if you hit the ICU with a hemoglobin 12, you had to get transfused, even though the cardiac anesthesiologist, thank you, David, had done a fantastic job of making sure the patient was adequately volume filled. So we created TACO in all these patients. Weirdly, 30% of all patients arrived in the unit needing a transfusion by these criteria and got it. Do you know what the incidence of increased transfusion was? 30%. Surprising that. Therefore, you get 1 transfusion as your median, which is exactly the number of transfusions these kids got on arrival in ICU. Not because of any other reason. Oh, and just to add insult to injury, they had a stroke in the conservative group. Now, I'm not saying that anemia and restricted transfusion caused a stroke, but I'm saying with this few patients in the study, you can't rule it out and you need to go looking harder. Again, have an elephant. Finally, biventricular repair data, the last recommendation. So again, we're using the same 3 favorite randomized control trials of mine, the only ones we get presented. Jill's study, we just talked about the fact they forced transfusion, which makes the data not work. The TRIPICU subgroup, they forced transfusion too. But contrary to the statement David made, when you look at it, they actually didn't show non-inferiority. They failed to meet that criteria, and they say so. They just don't say so in big, bold letters because no one likes the fact that the primary outcome, the only thing the study was powered for, didn't meet criteria. They failed to show it wasn't inferior. And if you look at David's slide, I love that he put it up there because it saved me a slide. They had increased modes in the on that histogram in the patients who got restricted. Finally, there's Dr. Gass Baker's study about safety and effective red blood cell transfusion, a great randomized controlled trial, which unfortunately didn't even show a statistical reduction in transfusion. So you can't use that data either. Elephant, elephant, elephant. What I'm saying is that the problem this paper has isn't that it's saying bad things, is that it's presenting recommendations that pretend to tell people there's a number at which you should transfuse, and there isn't. It pretends to tell people that you could transfuse below that number or beyond that number if you want to. But once you give people a number, you tie them to it. And once they have that number, they're going to need a really good reason to not transfuse. So those children are put at risk while people hum and ha and try to decide against their better judgment whether they should transfuse or not. I would suggest instead that we use the using blood entirely reasonably recommendations. They are that no hemoglobin number equals transfusion ever, that you should always have an indication to transfuse, and that those indications should be based on oxygen delivery and tissue perfusion. Therefore, we should measure end organ function where possible and use the surrogates we have when we can. Basically, when you feel the need to taxi, don't. Uber instead. Thank you. That's what I got.
Thank you, Dominique. A great presentation and debate. And I'm I can't activate my video, but it's not a problem. I think that maybe we should give some time to David to answer, maybe if you want, before taking the question.
Yes, thank you. Thank you very much. Thank you, Dominic. That was a great presentation. I really enjoyed your enthusiasm. And I do actually think that I do agree with you, but it's not because there's no evidence to support a restrictive transfusion that there is evidence to support a liberal either. And I do agree with your recommendation at the end. And I think that the good thing about those debates is when we come to an agreement is I think we should think wisely when we transfuse. And as you said, I think it's probably what most people do. But we still do see some patients being transfused for the sake of reaching a number. I don't know what that number should be. But if there's no indication, I think there's no need to transfuse. I'm afraid it will be very hard to have evidence. And it, for somebody like myself who does try to do research in pediatric cardiac patients, it's extremely hard to get the number that they get in adults. So I suspect those guidelines will always be weaker than the adult guidelines. But I think if we put our efforts together, maybe one day we'll have enough number to give some meaningful recommendation. So I think we're not that far from each other.
No, I can, David, I completely agree. The worst thing about watching your presentation was agreeing with it. I think the big part for me is the unfortunate side effect of the taxi recommendations is we put numbers against blood transfusion again. And I don't think that's a positive in our practice. I think the strongest reason why people still transfuse for a number is because someone feels they ought to, based on, things out in the literature and other people's concerns. I think the stronger the message can be that there is no number at which we should transfuse, that it has to be patient specific for measured indication, the better off we'll be.
And the most important is that I agree. I don't believe in the restrictive number, but I don't agree with the liberal either. So when people sometimes say, "Oh, scientific patients, we have to go above 13 or 130," I don't think it makes sense either. You may find some patients with cyanosis that are doing very well with 125, and then you may find some patients that won't tolerate 125 and needs to be back to 145. And I think I think we need to have a patient-centered approach. I agree with, and I hope that first of all, I hope that nobody's going to fund a restrictive versus liberal transfusion study ever, because I think it's a waste of time and money. And I hope that one day we'll have this patient-centered approach, being conservative, but being rational.
Yeah, the worry I have is that as an intensivist and an anesthesiologist, I'm short-term focused. And Jill's talk reminded me this afternoon of the importance of looking longer term. And I don't know what the outcome is to oxygen delivery to a brain of dropping the hemoglobin that child's used to by 40%. And I don't know if that's bad or good. I can't measure anything right now that tells me what I should do. So I have some sympathy for people who want to be more liberal. It's not my practice to be very liberal, but I do have sympathy for people who want to be more liberal because I actually don't have the information I need to know about whether I'm causing harm or not.
And if we want to take the question, there was a discussion in the chat box from Sam Shemi in particular, who was wondering if we should more look in detail at the impact of transfusion on the brain outcome or brain perfusion or brain. We don't know exactly what we should look at. But do you think maybe the other experts, do you think that this should be the next outcome for the transfusion studies?
Well, at SickKids, we use NIRS pretty much on every single case. I don't know if it's a good thing or a bad thing. I'm not sure it helps me every time, but I did have transfuse based on the NIRS once in a while, hoping that everything looks okay, but your NIRS is low, your hemoglobin is borderline, and then you transfuse, and sometimes you see an improvement. I do agree, and I think what's the case that Steve showed, our Jehovah's Witness patient, I don't know if it was mine, but I did have a similar patient about a year ago. And it was interesting to follow this patient in the ICU for those 5 days, because we were really thinking about, are we actually helping this kid or not? And the only way to know it is what Gil said, is we have to follow those patients and we have to understand what are they doing 2, 5, 6, 7, 10 years from now. Because I think you're right. I think those transfusion outcome are usually within 30 days, but we're not looking at 30 days. We're looking at a whole life for a CHD patient.
And I think it's part of the transition that pediatric cardiac critical care is making, which is from survival to thrival, right? That's all that matters now. We've reduced our mortality rates to incredibly small numbers. That isn't the measure. It can't be the measure. Third-stage mortality shouldn't really be a measure in our studies unless we're doing something really badly. You know, it shouldn't be possible to show those differences. But the long-term outcomes are vital.
Stephen?
Dominic, can I quote you on thrival?
Yeah, I just made that up. It's a real.
I like it. I like it a lot.
Stephen, you had a comment? Yep.
Yeah, so you may or may not be surprised to know, Dominic, I actually don't disagree with any of the clinical things that you suggested or said. I mean, I think most of us who do this regularly, you know, have a very similar philosophy. I will say about the taxi process that one of the things that was the biggest surprise to me personally when I got involved with it was the variety of practices represented in the room that were held each with 100% conviction by people.
And certainty, yes.
Yes. And so one of the things that became clear in trying to figure out how to put something down on paper for this was to really, I would argue that the goal was to get people to think more than it was to tell them what to do. You know, there were people who I could tell were hoping that something would be endorsed that would allow them to finally win an argument they'd been having with someone else at their institution for the last 20 years. And it was never going to be that because, as you point out, the evidence doesn't support that. You know, you're limited to the evidence you have, not the evidence you wish you had. That said, you know, you can point out to people that, for example, there are some reported cases, not many, as you say, in the literature of single ventricle patients going down to hemoglobin of 9 and not dropping dead. Is that enough to you know, base a real practice recommendation on? No.
Some of them are in my unit.
But it's news to some people. And, you know, I think at the same time, there's an overall tone that transfusing, you know, everybody who's cyanotic or everybody with abnormal physiology to a hemoglobin of 140 isn't the way to go. And I was surprised even back in 2017, how many places were still doing that. So I think the recommendations, I will defend them to the point that I think they serve a purpose. I don't think they tell anybody what to do, though.
Thank you. I think we had a great discussion. Thank you for the three speakers. We are just on time, so I think we had to move on. And
I will just, of course, coming from Saint-Justine, so I'll bring up a poll question of restrictive or not. And all participants are asked to give their answer. So the question would be probably on the next slide, or should I read it? So you have basically a patient with tetralgia fellow who's post-op, complete repair, who has no residual lesion, who's got a, who's on stable ventilator parameters, whose SVO2 is 75, blood pressure is okay, on epinephrine and milrinone, he's sedated, his blood gas is acceptable, very good values, blood lactate of 1. At what value, what hemoglobin value would you guys transfuse this patient? So we have 239 participants, so let's see.
what we should do or what we think we do?
What we should do. Because what we think we do, none of us know. That has been shown multiple times. So we have about, we're getting there. Fascinating.
Can we see those results? I can't see them.
I'm waiting for, we have only half of the respondents.
Okay.
I'm amazed is that I remember when Jacques did his study, he showed a normal curve for the results at a higher value, and this is what we're going to see right now. I'm going to wait a few more seconds. We have 50% of participants have answered. I'd love to get to 75%, but I think it's really slowed down. Okay. I'm going to end the poll. Does everybody get to see it now? This normal curve was around 10 of value when Jacques did his original study. So just to show you that it's now oscillating around 7 of hemoglobin, 7 to 8.
Fascinating. It really is.
Okay.
Yeah.
I think I'm going to close this one. We're going to ask the second question, the second poll. So it's a 3-week-old hypoplast, great repair, no complications, no bleeding, ventilator parameters are stable, SVO2 is 60 with a SAT of 80, blood pressure is adequate, heart rate is sinus rhythm at 140, low-dose milridone, epi, sedated, and the blood gas is normal, lactate is at 1.2. At what value would we transfuse this cyanotic child? I feel like
maybe ask that same question when the FiO2 is down to 25%.
Yeah. Where 50% of participants have answered. Everybody try to participate. We're going to wait 5 more seconds. And here's the answer. So the hemoglobin's around 9, 10. So not surprising.
But as I said, I would be curious to see that if people really do that in the practice.
Absolutely, it's two different questions, honestly.
Yeah, great point. Thanks.
Okay, next slide. So I'm going to present Dr. Joyal, who's who I work with at Saint-Justine. He's a professor of pediatric and an adjunct professor of pharmacology and therapeutics at McGill University and at University of Montreal. He's trained, he did his PEDS training, PEDS critical care at Saint-Justine, and then he did his pediatric cardiac ICU and ECMO fellowship at Great Ormond Street Hospital, and did a postdoc research fellowship at Harvard Medical School. And he's been our ECMO director here for the last year, I think. And so Dr. Joyal, go ahead.
Hey, thanks, Bauk. Thank you. It's going to be a hard act to follow with this lively debate with Dominique and David. Amazing conversation so far. I would like to thank the organizers for this phenomenal meeting and for the participants all over the world. This third session is on ECMO. So we have 3 great speakers again from Edmonton and Toronto, and we'll be covering a broad range of challenging ECMO topics. We'll begin by examining how to avoid ECPR with Dr. Ryerson, and if it fails, discuss the proposition that early introduction of ECMO is better than too much inotropes with Dr. Christian. Finally, we will explore the use of ECMO in transport with Dr. Guerra. So just a brief reminder for those who joined us a bit late, this is a Zoom webinar, obviously. And so we'll take your question in the Q&A section. And if you vote on the questions, we'll know which one are most pressing to answer. So we'll take the last 10 minutes to answer questions at the end. Each speaker is given 15 minutes. So we'll start, without further ado, we'll start with Dr. Lindsay Ryerson. So Dr. Ryerson is a staff intensivist in the pediatric cardiac ICU at Stollery Children's Hospital in Edmonton. She's the cardiac lead for the ECMO team and co-chair of the Stollery Resuscitation Quality Committee. She's actively involved in the ELSO Registry Committee, and her research interests include anticoagulation and ECMO. So today, Dr. Ryerson will tell us how to avoid ECPR. Take it away.
Thank you. Let me just. All right, can you hear me?
Yep.
Terrific. So good afternoon, everybody. I wanted to thank Ben and members of the organizing committee for asking me how to speak about how to avoid ECPR. And I will preface this saying that this is a subjective viewpoint, and it's based on a little bit of data, really trying to identify those patients at risk for cardiac arrest. I am going to only discuss cardiac patients, and I really have chosen to focus on trying to avoid cardiac arrest with potentially some proactive strategies that you can try to see if you can get your critically ill patients on support prior to a cardiac arrest. So as everybody knows, ECMO is a heterogeneous is used in a heterogeneous but carefully selected group of children who are thought to have refractory but potentially reversible critically ill disease, and with a very high risk of mortality. And when we add into that cardiac arrest and ECPR, the risk may go up with prolonged chest compressions and low flow. But in these patients, survival without ECPR is rare. And so these patients are really redefining reversible organ physiology. So ECPR was first described in 1992, and we know the use of ECPR is increasing in pediatrics and in adults. So if you look at the ELSO 2016 recent report, we know that from 2009 to 2015, the use of ECPR increased by 35% in neonates and 67% in pediatrics. And when you look at different reports, especially single center reports, what makes them difficult to compare is that everybody's using a different definition of ECPR. So if you look at the two top definitions here, they're both taken from the most recent edition of the ELSO Red Book, but you can see that the pediatric definition is not the same as the adult definition. And so it's not until 2019 when the final definition there, the application of VA ECMO in patients in whom conventional CPR is unsuccessful in achieving sustained ROSC, that is now the ELSO registry definition. And in 2019, the Epstein guidelines picked it up for their in-hospital cardiac arrest. So it makes it difficult to go backwards. Now, as you all know, ECMO itself is not a treatment that specifically causes organ recovery. Rather, it's a treatment that replaces organ function to give time to see if organ recovery can occur. And we know that it has lots of theoretical benefits, especially in the low flow period where it can give you organ perfusion with oxygenated blood. And it has benefits, we think, in the post-resuscitation phase where it's very easy to target temperature control, and there may be some benefits on microvascular perfusion. So this talk would actually be quite a bit easier if all I had to talk about was ECPR. Avoiding it is a little bit trickier. But when I think about ECPR, I think there are three keys to success. And patient selection is the first one. It is the biggest decision to make about ECPR, and the decision about your patient's ECLS candidacy should be held preemptively, documented in the medical record. You should not be having this discussion while you're doing CPR. The second key to success is practice, practice, and more practice. So every team and institution will do ECPR differently, and there's no one way to do it. For example, at Stollery Children's Hospital, we will only cannulate patients in an ICU, in the operating room, or in the cath lab. If your patient arrests in the emergency department, that's after an in-hospital cardiac arrest, or on the floor, that patient will have CPR until they get to their respective ICU. Our ECMO team has done a lot of work to make sure equipment is always in the same spot. We have fan out call checklists. We have cannula chart checklists. We have blood priming checklists. So everything is well protocolized. And I think that's one of the keys to success when you have a small group of people who are working toward the same common goal. But the third key to success is the same as with conventional CPR. And I think you have to have some way to monitor your quality of chest compressions. And you can use all three of those or one of them. I'm not sure the data is there to say which one's better, but in your haste to get on to support, I think you have to make sure you are monitoring the quality of chest compressions. And there was an interesting study that came out of George Washington University by TABE. It was in Pediatric Critical Care Medicine a couple of years ago, where they videotaped 11 conventional CPR and 6 ECPR, and they compared the videos with accelerometry data and telemetry, and they found that the ECPR cases were generally longer than conventional CPR, which isn't really surprising. There were more frequent chest compression interruptions, which again may not be surprising if you're centrally cannulating, but personally is the bane of our existence at Stollery. But they also had lower end tidal goals, and the chest compression rates were less likely to be within the goal range of 100 to 120. So I think if you're doing ECPR, don't forget about basic BLS and good quality chest compressions. Now, intuitively, it doesn't really make sense that cardiac ECMO survival, and I have only short-term results, sorry, Gil, is as good as ECPR. You would think with this period of no flow prior to CPR starting and then low flow that these kids would really do worse. But I can't definitively tell you that the survival outcomes are worse, as the data is mixed. But it seems that prolonged low flow or pre-arrest state necessitating high-dose inotropes as pressors may be equally noxious as cardiac arrest. And some of the potential reasons why ECPR patients, now these are for the most part surgical patients, may do as well is that we have an ability to treat myocardial stun without the use of inotropes and vasopressors. There's immediate institution of good perfusion and oxygenation. And again, it's easily to achieve targeted temperature control and improved microvascular perfusion. Now, the neurodevelopmental outcomes after ECP are not as well reported, and the majority of them will look at pediatric cerebral performance categories, which is a pretty gross measure. So we know that arterial blood pH pre-ECMO and early on ECMO and peak lactate levels are strongly associated with mortality post-ECPR. Now, these associations may reflect those patients who had a severely compromised circulation before cardiac arrest and thus may have benefited from earlier introduction of ECMO support. It could also reflect those who do not have adequate CPR, and it could reflect those patients who didn't have adequate ECMO support, usually with flow soon after their cardiac arrest. However, the duration of CPR is not a consistent predictor of survival. And again, I would argue that the quality of your CPR really plays a role here. But this suggests that earlier cannulation is of benefit, and that a priority when ECMO is used is to optimize flow. And what would support this argument is some of the data from the Melbourne group with their sepsis patients and the benefits of central cannulation and high flow. So we also know that there are some physiologies that won't do well with conventional CPR, and these really are the patients that I worry about. And I spend a lot of time talking to discussing with our surgeons about cannulating. And so it's particularly those patients with a cavo-pulmonary connection and passive pulmonary blood flow that are really hard to effectively resuscitate with conventional CPR. These patients often have progressively failing Fontan and Glenn circulations with elevated systemic venous pressures, which sets them up already for decreased cerebral and other end organ perfusion. And then you add high intrathoracic pressure during conventional CPR that's going to restrict their effective pulmonary blood flow and oxygenation, as well as increase their cerebral venous pressure that further limits their cerebral perfusion. So this is the group I really worry about. There's other groups with limited stroke volume, often from severe AV valve regurgitation, that have limited output with conventional CPR as well. So I wanted to switch tacks a little bit and just present some recent data, courtesy of Jeff Alton and the PC4 group, to look at, exclusively arrests in the cardiac ICU. And you can see from this data that it occurred in just over 3%, with a higher prevalence in medical patients versus surgical patients. And more than half of these occurred in the first 48 hours after admission. Now, we know that if you look at the risk factors for postoperative cardiac arrest, so prematurity and neonatal age, presence of STS risk factors, a higher stat category, none of these are very modifiable from an intensivist's point of view. And similarly, when you look at the risk factors for a cardiac arrest in medical patients, these are not modifiable. And we also can see that any of the medical patients had lower survival after cardiac arrest. And you can see that ECPR was used in almost a third of these arrests, with only a hospital survival of almost 40%. If we again look at the PC4 data to look at ECMO, not just ECPR, we know that patients who were younger, who were sicker preoperatively, and those who had a longer intraoperative support time and those with a more complex repair were more likely to need ECMO postoperatively. Again, there's no surprises there. It was interesting that the peak vasoactive inotrope score in the first 2 hours was not associated with ECMO. And then when we look at the medical patients, we can see that acute heart failure, so those are generally patients who present with myocarditis or an exacerbation of their usually dilated cardiomyopathy, that was associated with ECMO. Again, with the median time to cannulation only 9 hours after their admission. You can see when you look at the mortality in the group who had ECPR, so you can see that the medical patients did much worse than the surgical patients in that they didn't survive. And the hospital mortality for patients requiring ECPR compared to those with just cardiac post-surgical ECMO was pretty much almost the same. So I wanted to take a look at our experience at Stollery. So I just got our last 2 complete years of data, and half of our cardiac ECMO was ECPR. It was divided 3/4 into surgical patients and 1/4 in medical patients. And when I looked at our lactates pre-cardiac arrest in the 21 patients in which I had access, it was 7 with a very wide range. We've worked really hard with simulation to try and get our cannulation times down. And so that I was pleased to see, with a median duration of just under 30 minutes. And again, the survival, albeit only to hospital discharge, was similar to the PC4 data. And you can still see the difference in survival between the medical and the surgical patients. The 2 medical survivors were someone who'd been cannulated with a blocked shunt, and the other was a sepsis myocarditis patient. So if we have to say, before we talk about how to avoid ECPR, we have to say, what do we know? We know that medical patients have a higher risk of cardiac arrest compared to surgical patients and a lower survival. We know that cardiac arrest is going to happen usually closer to when they're admitted or post-extubation, especially in those patients who have poor cardiac reserve for the transition to non-invasive ventilation. We know that the severity of their arterial blood acidosis is independently associated with mortality, and patients with a cavopulmonary connection are going to do worse. And they do worse on ECMO too, generally secondary to problems with cannulation strategies and often no great exit. And then we also know that there's not a lot of modifiable factors in those surgical patients. So I think when I think about how to avoid CPR, the two biggest things I can think about is, as we talked about, is one is candidacy and two is communication. It's different in pediatrics and in adults is because I can't cannulate this patient. I need my surgical colleagues to help me with that. So I think an ongoing dialogue with the surgical team is really important, not only to discuss the candidacy, and if this patient is not felt to be a candidate, we often have discussions among the medical group for high-risk patients, just so we get our team on board. But it also needs to be discussed with their primary surgeon, not just the surgeon on call, and documented in the medical record. And then I think the other key is to really think about all extracorporeal support early, and specifically in those medical patients. If they have deteriorated quickly enough that they've landed in your cardiac ICU, the first question you should be asking is, should we be putting in a VAD? And that you should be having that discussion before you're even talking about intubating them. We often have ECMO surgeons and OR teams beside us when we're intubating these patients because of such a high risk can be seen with induction of arrest. And finally, the ongoing discussion with the surgeon and the surgical patients is, can something be done different than the medical management we're doing to try and improve these patients' oxygen delivery? Does their sternum need to be opened? If it's already open, do you need a bigger sternal strut? And are there residual lesions that you may or sometimes do not know about that need to be fixed? And do they need a TEE? Do they need to go to the cath lab? So, you know, what we have at Stollery is a system that we just call level 1 alert, that the intensivist makes that decision, and it allows the team really to prepare and plan next steps. And this could be done prior to a cath. It can be done as patients are coming out of the operating room or at any time in the ICU. It happens as well with some of the NICU patients, but as I previously said, we will only cannulate in the PICU. So if a neonatologist is unhappy with their patients and there is a decision to put them on alert, then they are coming down the hall to an ICU. And that's really because our team has practiced in our area and people know where the equipment is, and the team knows how to work well together. The other advantage of ECMO alert is we otherwise don't have a surgeon in-house. So when a patient is on ECMO alert, there's a discussion with the cardiac surgical fellow who is now in-house, and is a discussion with the staff surgeon that they know that we're worried about this patient. So other proactive things that we're trying to do to try and avoid cardiac arrest, which is the goal, is we've started doing some just-in-time bedside teaching that happens twice a day to really discuss the overall patient strategy, and are there some things that may precipitate an arrest? And this is a team with the nursing and the RTs and the ECMO team and the medical team that everybody's involved in. So to identify, are there some things that may precipitate arrest? Suctioning would be one example. And is there something different about this patient's pathophysiology that may change how you run an arrest? Do you have to make sure you have another pacemaker? Do they have a difficult airway where you may need help if they're already extubated? Is there different equipment that you might need? And does this patient need to be on ECMO alert? So I think that has helped our overall team just in thinking about strategies for management of these patients. preparation for high risk intubations and extubations. And as I said, often patients will be on alert for that procedure, and we will have a surgeon and an OR table outside the room as we are intubating some of these patients. Now, I wish I could tell you that there is a magic pH or a lactate or a mixed venous, at which point we should think about cannulating these patients. Alternatively, is there a vasoactive inotrope score? But to be honest, I don't have that data. And there was a trial that Giles Peak was quite a while ago was trying to get underway to look and see whether early intervention with ECMO versus conventional care for low output would make a difference. And there was going to be a concurrent prospective economic evaluation as well. And the trial never got underway, I think, for a couple of reasons. One was funding, but the second one is that nobody could agree on the patient entry criteria. Should it be different for a single ventricle versus a biventricular patient? How much time are we going to give the medical team to try and improve their oxygen delivery before we're committing these patients to ECMO? But I think it was a very interesting idea. So if I had to think about the take-home messages, I've separated them into medical patients and surgical patients. And for the medical patients, really, once you've admitted, you know, I'm sure everybody can think about a myocarditis that rolled down the hall and you wish you had a surgeon beside you because you knew you were going to have to cannulate them. But for the more stable, decompensating heart failure patients, really have the discussion about a VAD and what would be how sick do they have to get before you're putting a VAD in them? Do they need to be on BiPAP? Do their kidneys need to go off? Can you not feed them at all? We talked a lot about ECMO alert already. Looking at the surgical patients, an ongoing dialogue with the staff surgeon, I can't tell you how valuable it is. I think they probably are sick to death when I call them. But in the patients that I'm worried about, I call them often. And if we can't rely on a vasoactive inotrope score, are there other proactive things that you can anticipate in this patient's course, such as those that I've listed here, that may keep you out of trouble? So there are still a lot of knowledge gaps when it comes to cardiac ECMO and specifically cardiac ECPR. As I said, I can't tell you if there are specific clinical predictors of the need for ECMO prior to their arrest. I suspect they do differ between single and ventricular patients. The relationship between the duration of CPR and mortality is controversial, and it's speculative, but I would say that it's probably the quality of CPR that plays a bigger role than the duration of CPR. Similarly, where should we be cannulating these patients? I know lots of centers that even if their sternum, the sternum was recently opened, they're still cannulating through the neck. And there is some data to show that cannulating peripherally is protective, but is that because there was a long pause in chest compressions while you were cannulating? Similarly, if you know you're going on to ECMO, do we have to give epi every 5 minutes? I don't, but I don't know if that has ever actually been looked at. Everybody talks a lot about targeted temperature management, but is there a role of hypothermia specifically when it comes to long-term neurodevelopmental outcomes? Sorry. Thanks, everybody. Thanks for your attention.
Great, thank you very much. I think I'm having a bit of trouble with my camera now. Can you hear me? Yeah, okay.
That's great.
Sorry about that. Yeah, so Gil had a comment, but maybe if you don't mind, we ran a bit over time. We started a bit late, so I let you go, but I think we're 10 minutes late. So we'll try to catch up a little bit at the end. So the next speaker is Haley Christian, but thank you so much for an amazing talk, Lindsay. That was really interesting. Dr. Christian is a staff physician in the cardiac critical care unit at the Hospital for Sick Children in Toronto. She completed a pediatric critical care fellowship at BC Children's in 2017 and went on to complete a cardiac critical care clinical fellowship at Boston Children's Hospital in 2018. She's currently working on a Master's of Education at the University of Toronto and is the Competency Committee Chair for the PCCM Fellowship at Sick Kids. So today, Dr. Christian will make the case that early ECMO is better than increasing vasoactive agents. So a natural follow-up story for what Lindsay just told us. Thank you, and take it away, Dr. Christian.
All right, thank you so much. And I'll just share my screen here.
Oh.
All right. So hello, everyone, and thank you very much to the organizers of this conference for this opportunity, and for those in the audience that are listening, and for those moderating the sessions to help keep us organized. I suppose it may have been in my best interest to have Dr. Wernovsky give his opinion before I give mine, but I've been tasked with taking the position that early ECMO is better than increasing vasoactive and inotropic agents in the CICU. And it's sort of phrased in a debate form. I suppose those in the audience, your tool to debate is the chat and the questions afterwards. So I have no real or perceived financial conflict of interest related to increased ECMO use or early ECMO use. And I would like to acknowledge that ECMO and cardiac ICU are serious topics, but I may mitigate that impact somewhat with just one joke. So my objectives really relate to providing a framework upon which to make these sorts of decisions, as opposed to, as Lindsay mentioned, maybe hard and fast numbers and guidelines. The outline of this framework is going to focus on identifying the limitations of vasoactives and inotropic therapies, and in contrast, the benefits of ECMO, and the importance of understanding, if possible, the disease trajectory, or at least, as is sometimes more important, identifying when there's uncertainty. For number 4, I don't actually expect us as a field or as a session today to come to 100% agreement on the exact optimal timing of ECMO initiation. And, we have to acknowledge that the etiologies and clinical presentations of reduced cardiac output in our cardiac patients are really quite varied. But I think a conceptual framework can be very helpful. So in terms of our debate rules for today, we'll try to focus it down by recognizing that first, ECMO is a bridge across an evolving clinical decompensation. So as an example, we're not going to be talking about ECMO to support procedures or actually in the context of intubation of, say, a myocarditis. Second, the definition of early ECMO from my standpoint, so coming from my vantage point, will be the implementation of ECMO while the patient has baseline hemodynamics that are still responsive to vasoactives, moderate to high doses, and that implementation is not an emergent bailout strategy per se. We'll call it a little more than urgent, but a little less than emergent. And third, ECMO implementation will be occurring in this debate entirely in centers where logistics and safety of ECMO therapy is on a relative scale straightforward. And so in this debate, you're operating in a center that's familiar with this therapy. And finally, in this theoretical world of debate, money is no object and the ECMO machines are limitless. It's important to realize that in the real world, these latter two assumptions are variables that pragmatically impact the threshold to ECMO implementation, which can be a topic for another day. So we'll start with just some cases to get our decision-making juices flowing. So I'll read out this case for you just to help explain any acronyms, and then we'll ask the audience opinion. If you want, actually, we could just put that poll up now. On the indications for ECMO. There's no correct answer, and I acknowledge it might be too difficult to make decisions without more patient details, but I'm interested, and I'm sure others would be interested in just a gut feel for response from the group. So this first patient is a Norwood, relatively straightforward to begin with, but begins to develop a pulmonary overcirculation in the first day of life. Lactate starts to rise. Kid's okay, but goes forward with surgery on day 2 of life. Bypass time of 149 minutes. comes back with chest open, relatively standard with FB of 0.05, milrinone 0.5, and those are mics per kilo per minute, and stable hemodynamics. The echo shows good function, no significant TR, but the patient is increasingly hypotensive over the next hour. So things are happening actually relatively quickly. The lactate rises quickly to 17, the pH is 7.1, and despite adequate fluid resuscitation and reasonably high doses of vasopressors, can't seem to get on top of that hypotension, and then we require a couple of epinephrine boluses to maintain the BP. This patient is ultimately cannulated to ECMO in this context. So questions are, when would you initiate ECMO? Just pick one. What would be the most important thing that you expect, given this case, that would prompt you to choose to initiate ECMO? So the poll has been going for about 1.5 minutes, but since I've just finished speaking, we'll give it another 20 seconds or so.
Looks like the fourth choice on the poll has a typo. It should be 0.2.
Yes. Thank you. It would be very interesting if the responses were different, that being the case. Yes, it does seem to be lactate and the degree of inotropy required. That's sort of that first prompt to go on to ECMO. A few others are waiting until that need for ECMO bolus, and a few others are actually thinking, it's only an hour time frame. Maybe we can get ourselves out of this problem. That's interesting. All right, the second case is a 3-year-old. And again, we can put this poll up as well for the second case. Post-admission to the cardiac ICU with myocarditis NYD. So it's been here for 2 weeks with that presentation. Severely reduced biventricular function. It's not changed. Child's intubated, unable to wean muscle relaxant. Milrinone's optimized, a little bit of epi in the background. Has an evolving AKI, oliguria, is edematous, has pulmonary sequelae. Mixed venous is low and goes up and down depending on how much metabolic demand exists. The lactate, interestingly, is remaining normal. And you're struggling with this. Maybe you've got VAD in the back of your mind as that relates to Lindsay's talk. And overnight, the patient worsens. Mixed venous state goes down and stays down. Patient becomes anuric, blood pressure's dropping, and you've escalated your inotropic support to higher doses now. In your institution, in this theoretical world or in this situation, logistics of implementing a VAD are going to be at least 3 days. So now, throughout the scenario, what is the trigger? You can choose as many as apply. So you would initiate ECMO after intubation requirements. So before this scenario even started, if the patient needed renal replacement, if the patient became hypotensive and needed over that high dose of epi, only if that lactate rises, only if the parents agree to transplant, or you wouldn't initiate ECMO at any point, but you would initiate a VAD consult and get that done quickly. So it seems, not to bias the rest of the responses too much. We'll give it maybe another 20 seconds here, but you guys can all see, I suppose. But it seems that the hemodynamics are a significant flag for many of the practitioners and clinicians answering this poll out there. I think that's pretty common. That's what's in front of us as intensivists. There's a few there, 14% at this point, that wouldn't really consider ECMO in this case. And that may relate to some of the data that's out there that shows that patients post-transplant who are coming off of ECMO have worse outcomes. And so that's something important to think about when you're initiating ECMO in this patient. I might argue that if you would institute a VAD, if you had it, perhaps ECMO is a bridge to a bridge in that way. And those that would only do that if parents were agreeing to transplant, it's another conversation that you have to start having with these patients, parents, certainly. On the flip side, it may give you a chance to have that conversation. So the last case is a 2-day-old who's a postnatal diagnosis, so a brand new diagnosis of a cyanotic heart lesion with coarctation that comes on prostans and CPAP with preductal sats that are pretty good. But she decompensates over the next few hours with decreasing saturations and clinical signs of essentially intermittent pulmonary hypertension. And so PPHN is on your mind. But her condition worsens dramatically, more than you'd expect, over the next 12 hours. She requires intubation, and her intermittent pulmonary hypertensive crises become more frequent and more severe. And they're now associated with hemodynamic problems. You have to respond to those with higher inotropes. Her lung compliance starts to worsen, and you end up on very high ventilatory settings and nitric oxide. And throughout all of this, she returns back to a reasonable baseline, well-perfused, good lactate, but is heading towards what you think is a sort of pre-arrest scenario. So now, when would you initiate ECMO in this unstable patient? Would it be at the end of that scenario that I said, now because of high ventilator settings, that was PIPs in the 30s, now because of worsening instability and the potential for cardiac arrest in the context of pulmonary hypertensive crises? Would you wait on that ventilator 24 hours? Would you wait on the inotropes and see if it gets up to the 0.2 range? Or would you wait until you had signs of actual end organ perfusion issues? And so it looks like many of you, like I was theoretically for this theoretical patient, quite concerned about potential for cardiac arrest and considering ECMO for that indication. And some of you, though, would wait until you saw end organ perfusion issues. And some of this really becomes a feel that you can't quite translate over slides always, but getting a feel for the risk of cardiac arrest. And in these episodes of decompensation, how close does that patient go? So it's very interesting. And I hope that throughout these cases, thinking through these cases, you've probably hit very many of my main points that I'm going to get to in the rest of this presentation about the framework upon which to make these decisions. So, so one of the first things that I like to do when I'm talking about cardiac output is just remind myself of this important principle. And so this is Ohm's hydraulic analogy. And essentially what I want everyone to take away from this slide is just that blood pressure is not cardiac output. And any pressure in a closed circuit is related not only to the flow, which is analogous to the cardiac output, but also the resistance in that circuit. So keep this in mind as we explore the limitations of vasoactives and specifically the limitations of vasopressors. So what existing guidelines do we have to keep us headed in the right direction? Well, we have our ELSO guidelines that tell us to initiate ECLS in severe refractory circulatory failure. And they appropriately give us a little bit of leeway in our clinical decision-making with respect to the definitions of those severe and refractory phrases. They recommend using ECLS for cardiac failure when there's evidence of inadequate end organ perfusion and oxygen delivery resulting from inadequate systemic cardiac output and hypotension despite maximum doses of inotropic agents. And they sort of give us some parameters like a mixed venous less than 50 and a lactate greater than 4. But these definitions are still to some extent left open to interpretation. And you really as a clinician have to relate them to your patient. What is inadequate for your patient? How much reserve do they have? In terms of maximum doses of vasoactive agents, I'd argue that you really have to start thinking about the cons of these medications. So as mentioned, systemic vasoconstrictors will increase your SVR and increase your blood pressure as long as your cardiac output remains relatively constant. And the pros would be that you get a better perfusion pressure, but that's limited by decreased, at high doses, decreased peripheral perfusion, perfusion to the gut, to the kidneys, and increased systemic afterload and work for your heart. Inotropy and its corresponding beta effect chronotropy, on the other hand, are a little bit more analogous to ECMO in that they can increase cardiac output specifically. But this relies on the intrinsic limitations of a potentially already failing heart or already hyperactive and maxed out myocardium. And it increases your myocardial oxygen demand. So you may just not have, the heart just may not have it in it. Higher doses also predispose the myocardium to arrhythmia, which may compound other risk factors that are already there for arrhythmia, such as myocardial inflammation and systemic acidosis. We have options as well for systemic vasodilation, just reduce that afterload and increase the flow. But that, of course, is limited by hypotension and is not really as easily titratable as an ECMO circuit. And lusitropy, I think we can acknowledge, is probably not going to save the day. So this may be the most important part of this slide. ECMO is a reliable pump. It provides more consistent end organ perfusion to the kidneys, to the brain, to the gut, and all of those things can impact your patient's longer stay in the ICU. It can impact the need for renal replacement therapy. It can improve diuresis and lung health. You can improve nutrition potentially even. You also have a possibility for reduction in sedation needs because of the ability to respond to metabolic demand. And finally, and again, in relation to the ECPR talk, avoiding a cardiac arrest and the problems that leads us to. ECMO also allows you to rest the heart. So there's a reduced pressure and volume load, and therefore reduced myocardial work, more reliable coronary perfusion pressure, and you can rest the lungs that may very well be edematous in the context of a failing heart, and avoid that barotrauma. So this slide is really just meant to highlight the fact that even though, as Lindsay mentioned, we don't have good evidence that ECPR always has worse outcomes, we do see survival differences in the pediatric and adult population. Something to keep in mind. So earlier ECMO administration, if you think things are heading down the wrong way, could potentially be the answer to that earlier talk. Now, we don't, walk around with VADs just in case, and obviously ECMO has morbidity and problems to it. The primary risks really are infection and hemorrhage, but there also are potential issues for the patient systemically. Just to represent this point, we can quickly breeze through the neonatal cardiac complications from the ELSO database. There's mechanical problems, the most common you can see there being clots. There's hemorrhagic problems, and those scary ones are the ones that happen with intracranial hemorrhage. And you can, in fact, have ECMO-specific complications, of course, with hemolysis and impact on the kidneys that, in theory, you may be trying to protect with ECMO. So this last layer, and how I'll end my talk of decision-making framework for when to initiate ECMO, is really to emphasize the importance of understanding the problem that you're trying to help the patient get through. And ECMO can really be that bridge to the other side. Sometimes crossing that bridge earlier is easier. So what do you want to ask yourself, and how do you navigate this decision-making? In this heterogeneous landscape of pediatric cardiac critical care, determining the correct path can be difficult, but asking yourself these questions with respect to risk profile at baseline, severity and etiology of your impaired cardiac output, and the limits to the risk that you're willing to accept on and off ECMO will help you figure out the best path for your patient. There is a pursuit of generalizable knowledge. And this is an example of a study of stage one palliation patients that shows mortality associated with a low mixed venous. But really, as clinicians, you have to take the data of the patient in front of you to help you decide the best trajectory. And if you'll indulge me, I'll close with an arguably imperfect analogy. So think of the river as your patient trajectory, and think of the rapids as dangerous instability. It's important to the best of our abilities to be able to anticipate whether those rapids are coming or at risk of coming. If the rapids lie ahead or at risk of suddenly appearing around the bend, is a vasoactive and inotropic kayak adequate to get your patient through a period of rocky instability and acceptable risk? Or is it safer to take the ECMO bridge? As much as possible, it's important to anticipate what lies at the end of that bridge, but remember, a bridge to understanding is still an important bridge. So probably many of us remember that we've had to go through the rapids with our patients, especially in the middle of the night, and wished at times, perhaps in retrospect, that we had made different decisions. And yes, that is me whitewater kayaking for the first and as yet only time in my life. So I'll end with that, and thank you all for listening to my talk. And I hope at least some of what I've said you agree with.
Thank you very much, Haley. This was a great talk. We're way over time, unfortunately. I'm not very good at this virtual timekeeping. I have to find a way to wave a bit more loudly. But our final speaker is Dr. Gonzalo Guerra. Dr. Guerra is a staff intensivist in the Pediatric Cardiac ICU at Stollery Children's Hospital in Edmonton. He moved there from Argentina 16 years ago to complete his pediatric critical care fellowship and never looked back. He completed a master in clinical epidemiology and recently obtained his PhD. He is the co-director of the Stollery Pediatric Transport Team, and transport medicine is one of his many research interests. So today, Dr. Guerra will share his expertise on ECMO in transport. Thank you.
Okay, thank you very much for the introduction. And just, I want to say thank you for the organizing committee to give me honor to present to you about ECMO and transport. So I have no conflict of interest other than after Gil's amazing talk and Dominic's very entertaining talk. I don't think mine is going to be as good or neither as entertaining, but let's give it a try. So so there have been many papers published on ECMO transport, but the majority of them, they only report they are only one single center experience. They are small numbers, and the majority of them include also neonatal patients, some of them assisted for respiratory reasons. That being said, even in the ELSO Red Book, there is a chapter on ECMO transport with some suggestions and recommendations. So what Ben asked me to do for you today is just to show and share some of the experience that we have had over the last years with our ECMO and transport team. So I'm gonna show you some data of a retrospective cohort study of all the children from newborns to 18 years of age that has been transported by our ECMO and transport team here at the Stollery Children's Hospital. So these patients are from 2004 to 2018, but I can tell you that then after the numbers I'm going to show you in 2018, we did 11 transports, and in 2020, so far, 5 more of them. So as you probably know, but this is more for people outside Canada, we have a very extensive geography. Our center is the ECMO referral center for Alberta. We also go and retrieve patients from Saskatchewan and Manitoba, and that's a very large geographic area. And also, as I'm going to mention later in my talk, the weather sometimes doesn't help or contribute with our management of mobile ECMO.
Gonzalo,
yes.
Have you shared your screen? I don't think anyone can see your slides.
Sorry, maybe I didn't do that. Okay, let me just do that. Is that working now?
Yes.
Okay, perfect. Sorry. There goes the map, and there goes the plane in the cold weather. So we'll talk about that. So the way that our service works is usually we get a call from one of the referral centers. That could be usually Calgary, from one of the pediatric centers, Saskatchewan, or one of the pediatric centers in Manitoba. And that the coordinating center links us, the intensivist, either in the general PICU if it's a medical patient, or the cardiac ICU if it's a cardiac patient, and we organize support for that patient while our team is getting ready, and then we deploy our transport and ECMO team to go and retrieve that patient. Now, there is two ways of actually transporting, or the definition for ECMO transports in the literature. So the primary transports are those that are, that one center goes to the referral center and performs the cannulation and then transport the patient back to the ECMO center. So in our case, our primary transports are those where our ECMO and transport team went to the referral center, did the cannulation, and then brought the patient back to the stollery. Secondary transports are those that the cannulation is performed by the referring facility. So that could be the team in Calgary or in one of the pediatric centers in Saskatchewan or in Manitoba. And then our team then goes and retrieves the patient and brings the patient back to the stollery after it has been cannulated by their team. I also divided our secondary ECMO transports from centers with and without an established cannulation program. So we have been in close relationship with Calgary, and we have developed a program with them, with the Alberta Children's Hospital, where they actually have an official cannulation program, and that did common training with us. There is established protocols and a shared practice with them that facilitates to do secondary transports with that specific hospital. And I will talk a little bit about that. In terms of outcomes, we look at transport times, we look at complications, PICU length of stay, and ECMO and hospital survival. So in terms of what kind of equipment we use for the pump and console, the majority of our patients have been done with the Jostra Rotaflow from Maquette. That being said, in the last year, we moved into the cardio help. Oxygenator, we have used the Quadrox T for the majority, and again, we changed now to the cardio help, and we use heparin-based coated circuits. And in terms of heaters, that also has changed. The majority of the transport that I'm going to mention use the Gamer heater, but lately we have actually switched to the Striker heater. And that's going to refer later is an important factor. So for our ECMO transports, you're going to see the majority of them, 62% of them came from Alberta Children's Hospitals, 25% of them from Manitoba, and only 12% of them from Saskatchewan, and only one actually was from here within the city. These patients, I just wanted to highlight the majority of them were not cardiac, but about 41% of these patients were cardiac, had a cardiac diagnosis. In terms of CPR, 20% of these patients have CPR pericannulation, but only 4 of them actually have eCPR based on the definition that Lindsay mentioned before, which is active compressions during cannulation. So a lot of these patients were unstable just prior to going on ECMO. In terms of types of ECMO, we have that the majority of were VA ECMO, with almost 80% of them being VA ECMO, and the majority of them, again, were peripheral cannulation compared to central cannulations. Sorry, as you can see, in terms of who was performing the cannulation team, 60% of the patients were actually cannulated from surgeons from the referral center with an established ECLS cannulation program that will be the Alberta Children's Hospital. Now, in terms of the number of secondary transports, as you can see, the majority of them, we did not actually perform the cannulation, but the cannulation was done by the referral center. When we look at team composition, that has been described in the literature, going from 5 team members for the transport and ECMO mobile program to 10 to 15 members. So usually our team works that we have one senior primer from the ECMO team, so one ECMO specialist, one transport nurse, one transport respiratory therapist, and one ECLS trained physician. And that could be either one of the staff intensivists or one of our critical care fellows that has done the ECMO course. And then depending if it's a primary or a secondary ECLS transport, we might be taking with us a surgeon to do the cannulation. In terms of modes of transport, because of geography and distances, we had only one that was done by ambulance. That's the one that we did within the city, but the majority of them we use airplanes, and for that they usually have been either a propeller of a Learjet. Just the very first one used an Hercules, which was very cool, and I was not involved in that one. In terms of transport distances, as you can see, the primary transports are significantly longer and they are further away, and that's because they come mainly from Saskatchewan and Manitoba, compared to the secondary transports, which a lot of them came from Calgary, which is at a closer distance. I thought also was important to look at other factors. So time to dispatch, that has been around, is similar to what has been described in the literature. It's just about 2 hours to deploy the ECMO and transport team to go to one of the referral centers. Again, that's similar compared to other centers. But if we look at stabilization time, it obviously takes significantly longer for those primary transports when we need to arrive there, assess the patient, and then do the cannulation, compared to those secondary transports that usually we stay around for a median of 2 hours in that center, just adjusting a few things, doing the transition from their equipment 2 hours, and then just bringing the patient back to Stollery. In terms of time of ECLS to ECLS cannulation, from where the call got into us, again, has been significantly longer from the primary transports compared to the secondary ECLS transports. Then in terms of duration of the transport itself, which is very important, like the whole duration since we leave until we get back to the Stollery Children's Hospital, as you can see, the primary ones take a significant longer time. So that's the median, which is 13 hours, but has been as long as almost a complete day. So that puts a lot of burden into the transport and ECMO team, and also has some difficulties in terms of logistics and working with other services like the air ambulance service and the regular ambulance services as well. So when we look at complications, what we did is we stratify or categorize the risk based on the Karolinska paper. So the Swedish are the ones that have the largest experience with ECMO transport, and they use this category of risk that they divided on risk category 1, which are high risk for morbidity and mortality if not addressed within seconds. Category 2, which are high risk for morbidity or mortality if not addressed within minutes. And I will show you then the category 3 and 4. So, and then they divide them before and after, before and during the transport. So when you look at before transport, can be console failure, error in the circular tension, pneumothorax, and during transport, we have similar problems, but all of them have been resolved quickly, which actually did not lead to any adverse events to the patient itself. When we look at the category 2, I think the most common one that we have seen so far, it was a poor cannula position, needing actually interventions before leaving, reposition, and actually adding another cannula to the patient. So about a quarter of our patients needed some tweaking and some adjusting before actually jumping in the plane and bringing the patient back to the Stollery. So I'm not sure that actually this is a complication if it's addressed in a timely fashion. But again, this definition comes from the Swedish experience, and in terms of trying to maybe bring some consistency into the literature and reporting the same outcomes, we use this classification to try to categorize our complications. As you can see, CPR during cannulation is actually only a category 2 compared to a category 1, so I not necessarily agree. I guess it depends a lot on the situation for that particular patient. One thing that I wanted to highlight, it was the hypothermia. That was our most common complication. And again, not saying that it was untreated and actually led to adverse events or adverse outcomes for our patients, but because of weather and the inability to sometimes run the heater, especially between transfers, so from the unit or emergence from the unit at the reference centers to the ambulance, right? And the same from the ambulance to the airplane. As soon as we unplug our system, the heaters actually that we're using, they actually cannot function with batteries. So that actually is a significant challenge that we have been working a lot in the last few years, and we have been able to decrease the incidence of hypothermia for these patients. But as you can understand, going out in winter here with minus 20 degrees outside, a drop of temperature to less than 35 can be quite quickly. And even if it's right away, once you get into the plane and you plug in, you can actually fix it. So for that reason, as much as we can, we try to actually load these patients within a hangar instead of doing it outside, which is not always possible. In terms of category 3 complications, those are not immediate risk for morbidity or mortality, but has to be addressed. And I think one of the most common ones is inadequate ECMO flow and second cannula required, as I mentioned before. In terms of during the transport, I think one of the challenges that we have at the beginning was hypocarbia. And now with adding actually a different flow meter and be able to use less gas flow on the sweep gas, we have been able to actually tackle this problem and reduce its incidence. In terms of outcomes in the ICU, the mean length of stay for these patients at the Stollery Children's Hospital was significantly lower longer for primary transport with a mean of 31 days compared to the secondary transports with a mean of 13 days. Not really, I don't have really an explanation for it. As usually if depending on what the patients have, once the condition has been stabilized, sometimes they go back to their referral hospitals, but I noticed that trend and we need to explore further into it. Now, when we compare secondary transport with and without a cannulation program, we did not see any significant difference in PICU length of stay. In terms of survival, it has been described in the literature. We have no deaths during transport, and they are very rare all over the literature in peds and in adults. Our ECLS survival for this cohort was 76%. Which actually is a bit higher than our average for the unit. I don't think that ECMO is actually a benefit factor. I think it's maybe some of these patients are cannulated early on in the context that if they deteriorate further, they might not be able to cannulate, or we might not be able to get there on time. So that probably plays a role in there. When we look at survival for primary ECMO transport, so the ones that we went and cannulate, that was 90%. And for secondary transport, the survival was 74%, but this difference is not statistically significant. Now, the ECLS survival between ECMO cannulation programs, so for secondary transport with an ECMO cannulation program was 82% versus without a cannulation program, that's 59%. And that there is a trend there. So maybe suggesting that having an ECMO cannulation program in referral centers where they can early establish ECMO support might be of some benefit compared to them trying to do the cannulation without an established program that is supporting from us as well. Again, like for primary ones, not, but I think maybe plays a role in terms of the experience surrounding the cannulation process itself. So definitely has significant challenges. So to run an ECMO mobile or an ECMO transport program. So there is a lot of challenges in terms of organization from our center and from the referral center. So from our center, you need an ECMO program which has ideally a large volume, because you need a lot of expertise to be able to troubleshoot not in your unit, but in a different hospital, in a complete different environment, and especially to be able to troubleshoot in an airplane or in an ambulance where you are limited in space. There's a lot of noise around it. The lighting is completely different. You might not even be able to see very well, the color of your ECMO lines. So there's a lot of things like that when you are actually moving, the things become quite challenging. Also, it's important to notice that every single step that you move the patient is a possibility for adverse events or for mistakes. So when the patient is getting moved from the bed where the cannulation happened to our stretcher or sled, that's a moment for events to happen. The same when it gets transferred to the ambulance, there to the plane, and then once you get here to Edmonton, you go back to an ambulance and then to our bed here in the hospital. So all those transfers, they are a potential for adverse events, and they need to be looked closely. In terms of logistics, as Lindsay mentioned, for the ECMO team, we do a lot of simulations. So we practice this many times. We do those simulations with our transport team, and we also have checklists for this process, so we make sure we don't actually skip any steps and we can do it right. In terms of coordinating with other services, definitely is a significant challenge for us, especially when we go very far away. Like when we go to centers like Manitoba, sometimes the transport, as you saw there, have a median time of 13 hours. So the problem with this is that pilots with new regulations here in Canada, they time out, so they need to swap their crew, and actually that leads us sometimes for a significant longer time of us at the referral center before we can actually bring our team back home safely with the patient. So I mentioned longer transport times, potential for complications, and again, weather doesn't help, right? Like significant distances, the risk of hypothermia when the patients are exposed, and sometimes flights get canceled because of weather, and we have been stuck at the referral center for significant hours. I think it's important to also notice that depending if it's a primary or a secondary transport, there is a difference in terms of the urgency of it, right? So obviously when you do a primary transport, you want to make sure that you get there as soon as possible to be able to cannulate that unstable patient. Now, the advantage of having doing a secondary ECMO transport is that you can actually focus more on safety because the patient has already been placed on ECMO, and we just need to go there and do the transfer and bring Lee safely back to the storage. So in terms of maybe advice and some key components that we found that for an ECMO transport program, the first one that I will say is strong leadership, and that's not because of me. You see Don Wernovsky there in the right upper corner. He has been a great mentor for all of us. He actually helped to develop the ECMO and the ECMO transport program. You see Lawrence Lequi on the middle picture as well. They had an active involvement. And again, he was with Don, the persons that developed our transport ECMO program. You see Alan DeCane, the other director of our transport program, Lindsay, and on the bottom right, you see Jamie Blackwood and her crew, which are the team at the Alberta Children's Hospital. I think it's very important, and talking with it, what has helped us to develop this program is adequate and standardized equipment and training. So I mentioned simulation before, and in terms of adequate and standardized equipment, that means our equipment, but also if if we have a secondary transport, ECMO transport with a center that has a cannulation program like Alberta Children's, we need to be using the same equipment. We need to be talking the same language when we talk to each other, when we actually put the patients on ECMO, so things go smooth and there is no jams there. So we have common training, we review cases together, we have common protocols, and it needs to be a clear communication between teams during the transport and in between transport, so problems and issues can be fixed. This conversation obviously has to be respectful, and it's very important sometimes to have some common ground and some discussions about the indications for ECMO for these patients. It's important also to share a mental model that is our patient. And what I mean by our patient is not the story patient, but if I'm talking, with the Saskatoon, for example, and they have a patient, once we get involved, we consider that it's their patient and our patient. So we need to work on that way to make sure that we make the best decisions for that particular kid. I talk about a review of cases and simulation. And I think it's very important also to know that actually, although I just talk about inter-hospital transport, you guys probably move your ECMO patients around the hospital on a frequent basis. So a lot of things that we learn from the inter-hospital transport of these patients can be applied for intra-hospital transport, as they are also subjected to adverse events, and it's important to do them safely. And that's it. So thank you so much, and I'm open to questions.
Wonderful. Thank you very much, Gonzalo. That was an amazing talk again. So we went a little bit over time, but I finally remembered that we have a little break. So we have time for a few questions. We have three amazing speakers.
I tried to go as fast as I could.
I know you did great, but everyone went a bit over time, so it's okay. And we have, everyone can take a coffee at home now and lean back while we answer a few questions. I think okay, so there's a question in our comment chat, but there's one question from Sam Shami in the comment chat, in the comment Q&A, that asks, that congratulates you. Oh, sorry, maybe I'm wrong. I'm not quite sure who asked the question, but it doesn't matter. It's the question is, congrats on a challenging program, Gonzalo. How is it funded and staffed? You are muted, Gonzalo.
Sorry there. Okay, so we have our transport program. So this is a combined thing. So we have our ECMO program that is funded by Alberta Health, and then we have our transport program as well. So we just combine both when we need to do this transport. Now, when we go to other provinces, I believe then there is these agreements with the province of Saskatchewan and Manitoba in terms of for the transport of these particular patients. So we normally don't do transports of critical ill patients. We don't go and pick up critical ill kids in Manitoba and Saskatchewan unless they are ECMO transport. So there is an agreement between provinces there.
Okay. I guess all three talks pertain to timing of cannulation and the use of certain criteria to decide when we put kids on ECMO. But one of the characteristics of all the speakers is that they come from fairly large programs. One of the questions from the attendee is, could early ECMO cannulation lead to unnecessary intervention? Does anybody look at that? And I guess the question also is, with regards to the timing of intervention, when is it too early? I guess that this is the central theme of this whole discussion. So obviously going too late is likely bad. Waiting for ECPR is not the ideal outcome or desired outcome. But then, how do you define timing? And if you get survival rates of 73% with your transport ECMO, is there any indications that we're waiting too long? Is it better to go even earlier in smaller programs that don't have the resources that you guys have? Can you please, all comments actually on this indication or this timing of cannulation, and what would be the ideal timing depending on the size of the program, the readiness of the teams, which are not as big as some of the smaller units actually probably don't have your resources, Yeah.
Yeah, I think when it comes to ECMO transport, I think it's that fine balance that if you don't have the ability to cannulate at your center, and then you depend on the larger center the ECMO center to go and cannulate, is that fine balance between calling too early and actually calling too late, when the ship has sailed and maybe the patient is significantly unstable or goes into cardiac arrest. So I think that's why a model where other centers, other pediatric centers, even if they don't have the capacity because of volume to run an ECMO program, but and keep the patients, but they can develop a cannulation program, the way that we did with the Ability Children's, I think is very beneficial, because it gives you the opportunity to monitor that patient, don't jump on it too early, but at the same time being safe that you can cannulate if needed while you're waiting for us to get there. One of the limitations of the data that I showed you that I need to go back and look is there has been cases where we actually went with our ECMO transport team and we did not cannulate. Yeah. Like we ended up doing some changes. We ended up working together with the team at that particular ICU, and then we watched it together. We spent a few hours, and then we ended up either leaving the kid there in their ICU or bringing the kid to the stottery, but without ECMO. I can think about 3 patients that have been involved, but I have to go and look back how many more have been there.
But so maybe that would be an interesting follow-up question then. Did you set up a list of criteria upon which you will say cannulate now because this might be too dire if we wait, or we are going to go and establish a cannulate for you at a given time in your.
No, I think that goes to a very respectful, I say it has to be a respectful communication between us and the referral center. I think it's very difficult to put a strict criteria, and it has to be decided on the moment. And many times we are not the ones involved with the patients. We're not the ones that have been actually spending hours with them. So usually we get the full history. Sometimes we do give some advice or some suggestions, and then if there is, and we wait for a few hours, and if there is no improvement, then we follow whatever the referral center usually is asking for, as they are the ones responsible and involved with the patient at that time. Something important that actually, when I was reviewing the literature, I found in terms of process and teams composition is through the process, we usually ask the referral center to get consent before we mobilize our team to explain what the ECMO is going to be about, and if that's actually something that the parents want to or not. In reviewing the literature, I found that for other centers, they actually get the consent when they get there to cannulate and not before. But that will put you at the risk of mobilizing the whole team, for a long distance, for a very long period of time with a significant cost without knowing actually if that's the right thing for that particular patient.
Lindsay, did you want to comment on timing of cannulation?
Yeah, I think it's certainly different when you're looking at being in a surgical center versus what Gonzalo was talking about. I don't know if I ever worry that I cannulated somebody too early. I think when you look at some of the ELSO data that looked at, for example, the one by Mackenzie Ford that looked at all cardiac neonates, mortality was worse as for those kids who were cannulated with a pH less than 7.2. And even when we look at our own ECPR data, I presented that median lactate was 7 with a very wide range. 7's not very high. There's a lot of kids who, it's sometimes going up into the teens before I can actually convince the surgeon that we need to cannulate this kid. So, there's no data. I don't think everybody would ever say, oh, maybe somebody would second guess themselves if there's a really bad ECMO complication, but there's certainly no data that would go along to say that we cannulated too early. I think most of the data says that we cannulate too late, especially if they arrest.
Would you go as far as saying that the smaller the center, the least experienced the team, the earlier you should cannulate? Would you go that far? Because then you would also possibly run into the risks of more complication with the running the machine as well, the ECMO setup. So where is the trade-off? Where is the actual take-home message?
I wish I knew. There certainly is data in cardiac surgery and in ECMO that there is a threshold over which the more volume you do, the better your results are. But
Sure.
That's not to say that programs can't, similar to what Jamie's developed in Calgary, that's not to say that you can't develop an ECMO program and work in partnership with bigger centers. I think that what's been developed in Alberta is phenomenal. It's a bit different for smaller cardiac surgical centers, but I would hesitate to say that there's a magic number and that you should cannulate earlier. I don't think there's data to prove that.
Yeah, that's what in the ECMO transport literature is called as hub and spoke kind of strategy. Is you have your largest ECMO center as the hub, and then you have the other centers that maybe have lower volumes, but they can develop in conjunction with the hub center the capacity of cannulate and bring those patients safely to the hub and for their ECMO run until they are ready to be decannulated and discharged back to their center.
Great, thank you. Okay, sounds good. I thought I had another question, but we already answered it. So great. Any other comments, Haley, that you would like to add, or?
Hi, yes. No, I think really just reiterating what my co-presenters have said, but that there's always morbidity related with ECMO, and that's always a risk-benefit analysis, but certainly waiting to go on too late and having end organ perfusion issues can certainly put you in a position to have even higher morbidity when you ultimately go on to ECMO. So things like DIC or increased edema because of renal dysfunction. And so I think it really is a balancing act, but leaning towards early ECMO is actually the position that I would take and the position I was tasked with to present. Yeah.
Great. I think that's a very good summarizing statement, actually. So a tendency towards early ECMO in a case that are obviously warranted. Thank you very much for this amazing presentation. This was very insightful, very thought-provoking. And then I guess we will all have a break, 30-minute break.
So I'm going to just remind everybody that we do have a 30-minute break, like Jean-Sébastien just said. I have a little teaser because we were talking about anemia, blood transfusion, and neurological outcome out of the ICU. I think if you guys come to after the break, you may get the answer to that. So really, I would encourage everybody to come back for the abstract session. Fellows and medical students and residents have worked very hard on this, and it would be great if everybody really came back for that. So it's going to be at 4 o'clock Mountain Time, 6 o'clock Eastern, 3 o'clock Pacific. We'll still be here. Don't leave. Just take a small break. Thank you. I'm just being biased, but this is my favorite part of a day. I love hearing what people in training have done and their research and the future of what we're doing. And I get to introduce great people. So it's a great part of this day for me. So I'm going to start by introducing the moderator. Karen works at Saint-Justine. We've worked together a long time. Well, not for her. She's so young. How could it be a long time? But she's been at Saint-Justine ever since 2005 after doing her pediatric critical care and pediatrics at McGill, and then going to doing a pediatric cardiac critical care and ECMO at Great Ormond Street. She then did a master's in human factors and system safety, and we had the opportunity to work on a project together, which was one of the highlights of what I've been able to do. And she's been our program director since 2018 and done a great job at that. Jennifer Foster, had the opportunity of working with her at the exam board for critical care. She works at the IWK. She's the medical director for the Maritime Pediatric Transport with Life Flight. She's an associate professor of critical care at Dalhousie, and she trained at CHEO, not far from Montreal, and Royal Children's Hospital in Melbourne. And her clinical and research focus is improving the patient and family experience in the PICU. And from what Dr. Wernovsky said, we should be concentrating on that. She is leading a study on the presence of family at the bedside. And then Srin Murthy, who I haven't had the opportunity to meet, but I've heard such good things about him from Fiona. So is a pediatric critical care physician at BC Children's, associate professor of Department of Pediatrics for University of British Columbia. And he's been looking at infections in children in different environments and how to handle that, how to change the management of these infections in various settings, and how these various settings and healthcare systems will teach us about cost-effectively managing these children. So especially those with infections. So we have a great panelist, and I've read the abstracts, and they're 3 great abstracts. So I think I'll let Karen introduce the first presenter.
Thank you, Baruch, and really thank you to all the organizers. I think it's been a great day, and it's a great honor for me to introduce the next three speakers. One of the overreaching themes for me today has been looking beyond our traditional boundaries, so going beyond cardiac recovery to neuro outcomes and quality of life, and looking beyond the ICU for outcomes to guide what we do in the ICU. And I think you'll be as pleased as I am to see that our next generation is on the case, presenting their research on non-invasive hemodynamic monitoring, non-invasive ventilation, and outcomes beyond the ICU to help guide our tolerance of anemia in the ICU. Our first speaker is Armelle Bridier, who is one of our fellows here at Saint-Justine. The best hander over I think I've had the pleasure of meeting, really. And she'll be presenting her work on hemodynamic assessment by infrared thermography in infants after cardiac surgery.
Thank you, Karen. I try to, can you see my screen? Okay. Yes. So, good morning, everybody. My name is Armelle Bridier. I'm a PQ fellow in Saint-Justine Hospital in Montreal. As part of my master degree, I'm currently working on the hemodynamic assessment by infrared thermography in patients with, in children with cardiac surgery. I did this study with, under the supervision of Dr. Jouvet and in collaboration with the engineering team of l'École de Technologie Supérieure de Montréal. Excuse me. Oh, I can't. Oh. Okay. I have a little problem. Excuse me. Cardiac surgery is a crucial moment during which low cardiac output can occur. It is important to have a multimodal monitoring of the early signs of tissue hypoperfusion to detect the hemodynamic compromise early. The oxygen extraction is commonly used because it's an early marker of low cardiac output and is especially reliable for cyanogenic and non-cyanogenic cardiopathy. The peripheral perfusions evaluation is routinely used, but which is very subjective. A correlation between a gradient between central and peripheral temperature and a cardiac output has been reported in children after cardiac surgery in older studies. A gradient more than 5 degrees was correlated with impaired peripheral perfusion and cardiac function. But results was controversy and other studies was negative. In these studies, the technique and temperature measurement was not well described and relevant confounding factors were not taken into account. Our goal is to determine the correlation between the gradient between the central temperature and lower extremity temperature obtained by thermography and the oxygen extraction ratio in children after cardiac surgery. For this, we conduct a single center study at the Saint-Justine Hospital in Montreal, Quebec. We took thermal picture of children who had a cardiac surgery with cardiopulmonary bypass after parental consent. Photo was of patient was with external cooling, extensive skin disease or extracorporeal support were excluded, that is, could change the thermal gradient. Photo was taken with the FLIR 1 Pro camera during the first 24 hours after the surgery at the same time as blood test. From the thermal photos, we extract the central temperature in the internal epicanthus and the peripheral temperature in toes to establish the thermal gradient. This gradient was then compared to the concomitant oxygen extraction ratio calculated from arterial and venous blood gas. It's a preliminary analysis. Our preliminary analysis were performed on 22 patients. We analyzed 52 thermal photos, and the majority of the photo was taken between the 3rd and the 12th hours. This table represents the patient characteristic, clinical characteristic and demographic characteristic are on the right, and on the left we have percentage, median and interquartile range. 22 patients were included. The median age was 4 months, and there were more boys than girls. Our patients had cardiopathy that are frequently described in pediatrics like VSD or fallow. 18% had a ventricular dysfunction or pulmonary hypertension identified at the postoperative echocardiography. And cardiopulmonary bypass median time was 180 minutes. The thermal gradient median was 3.5, that is not very high, and the oxygen expression ratio was 36, that's not very high also. In this graph represents the thermal gradient as function of oxygen expression ratio. On the axis, we have the oxygen expression ratio, and on the ordinate, we have the thermal gradient in degrees Celsius. As we can see, we found a weak correlation between the two variables, with a Spearman coefficient of 0.29. However, what we can observe is that the thermal gradient increased 0.24 by 10 increase of oxygen expression ratio. So the main question is, why did we find a weak correlation? First, probably related to the too small sample size, and we expect to have 120 to 150 data pairs later. Furthermore, the involvement of confounding factors such as vasoactive drugs like milrinone, epinephrine, norepinephrine, frequently used in postoperative period, could impair the thermal gradient. The central temperature should also influence the thermal gradient, also for age and the type of cardiopathy. The patient didn't have a very high level of oxygen expression in our population, with a median of 36. There were only few patients with a low cardiac output, so we will also have to look at more in detail the characteristic of outsider patients, such as the few patients with low oxygen expression ratio, but a high thermal gradient. The low correlation can also be due to the infrared technology itself, like the FLIR1 camera lack of performance or other technical aspects. And maybe we need to better target our region of interest and have a more accurate measurement conditions. So to summarize, thermography could probably help detect tissue hypoperfusion signs after pediatric cardiac surgery, and we hope to show a more significant correlation with a larger data set after taking confounding factors into account and with a more reliable technique of thermal imaging acquisition. And finally, I would like to add that is a non-invasive tool which fits in well with the perspective of having the less aggressive care for our patient, as discussed earlier. Thank you for your attention.
Thank you, Ahmed. Just looking through the questions. If anyone has any more questions, you can put them in the chat or in the QA. There's one question here, Ahmed. If the vasoactive drugs can modify peripheral circulation and influence the gradient, do you think this is a sign that the therapy is working? There's an effective therapeutic intervention, or a problem with this kind of surveillance?
Sorry for my English, please. Karen, can you tell in French so I'm sure I understand?
Oui, alors si les médicaments vasoactifs modifient la circulation périphérique, est-ce que tu penses que ça fait que la surveillance est difficile. La surveillance est inadéquate vu que ces effets-là des médicaments qui ont des effets et centraux et périphériques, ou que c'est un marqueur de l'efficacité du traitement.
Okay, I will try to say in English. Confounding factors such as norepinephrine will generate peripheral vasoconstriction, which will change the perfusion and thus the hit of the extremity with which we can detect by the camera. We have two situations for me. Either the flow rate, the cardiac output will be. J'ai du mal à le dire en anglais, est-ce que je peux? Ouais. Donc, soit en fait la vasoconstriction est le reflet de nos amines vasoactives et permettent d'avoir un débit qui est un débit cardiaque qui est suffisant, et à ce moment-là, on aura une discordance entre la thermographie et l'oxygène extraction ratio qui sera à ce moment-là plus haut, enfin qui sera à ce moment-là plus bas par contre. Soit à l'inverse, on a une vasoconstriction qui est détectable avec la caméra, mais qui est le reflet d'un bas débit cardiaque, et à ce moment-là, l'extraction en oxygène sera plus haute. Et à ce moment-là, ce serait plus le reflet que la technologie fonctionne. Je ne sais pas si tu peux traduire pour moi, Karen.
So I mean, it's a great question. The medications, the vasoactive medications we're giving do have central properties and peripheral properties. And I think it's unclear right now whether the technology is a good one, or if it will help us, kind of tease out the details. I think that the fact that you have a small number, as you said, a small number of patients, and you're aiming to get to 150, maybe will give us more answers. Maybe the excellent care that's given in the ICU will confound your study. But I think it's a good new take on an old question. I remember being a fellow and the surgeon always calling and asking, "What's the toe temp?" How will you choose which hours to do this kind of surveillance? Will you do it intermittently? Can it be something we can use continuously to try to decrease blood taking or exposure to plastic?
Donc, l'objectif, ce serait d'avoir une surveillance continue. Le fait d'avoir une surveillance continue non invasive permettrait de détecter de façon plus précoce les signes d'hypoperfusion par rapport aux prélèvements qui sont faits de façon plus ponctuelle, ou bien par rapport à la NIR. C'est sûr que la NIR, c'est aussi une surveillance continue, mais là, on aurait donc une surveillance plus dans sa globalité par rapport à une surveillance plus locale, cérébrale, comme est la NIRS.
I have a question. Is that all right? Yeah, I'm wondering, have you seen or have you tried to compare doing a difference between esophageal and skin temperature with this method of measurement?
Karen, tu traduiras. Donc, on a en effet comparé la température centrale, qui est plus une température rectale qu'on prend chez nous, plutôt que la température œsophagienne la plupart du temps, à la température par thermographie. On a en effet une discordance qui va de à peu près de 0,5 jusqu'à 1,5 degrés. Mais j'estime que ce n'est pas embêtant, car ce qu'on veut voir, c'est un gradient. Donc, le gradient devrait rester le même à chaque fois. Même si la température n'est pas le reflet exact de la température centrale, le gradient, lui, devrait rester le même.
So the central temperature by thermography is not exactly the same as the esophageal temperature. There's a small difference, but the gradient is what you're looking at. So the gradient should still be a reflection of the change.
I want to look at Guillaume's question, which asks about the absolute foot temperature, not the gradient between central to peripheral. Did you assess that and how that compares with oxygen extraction?
Non, pas encore. Not yet.
Okay.
Not yet. But we will do this.
And Ben Sivarajan asks if there is a thought to correlate with somewhat more objective measures of cardiac output, like cath lab, MRI scanner. I had wondered, there's a Doppler that we use at the sternal notch, or is there any plan to correlate it with other things besides the AV difference?
Donc, en effet, peut-être que l'extraction en oxygène n'est pas le meilleur gold standard pour évaluer le débit cardiaque. Et puis, on s'est en effet posé la question d'avoir d'autres outils. Le but est quand même plus une étude observationnelle où on n'a pas vraiment on n'effectue pas d'autres examens sur le patient, mais ce qu'on voudrait faire, c'est au moins calculer le VTI pour évaluer le débit cardiaque de façon plus répétitive. À chaque photo, on calculerait à ce moment-là le débit cardiaque et le VTI au chevet du patient, mais on n'a pas prévu de faire de cath lab ni d'IRM cardiaque.
So yeah, great question. The answer of which maybe many of you have already understood, I don't need to translate, but is that they have thought of other markers of cardiac output. Right now they've used an oxygen extraction gradient, but are thinking of other non-invasive or feasible methods at the bedside to do after cardiac surgery, such as cardiac output by echo. And time is marching forward. So maybe just one last question, Armel. Can thermography be used as a continuous videography?
Yeah.
Or does it have to be subsequent images?
Non, le but c'est de faire une vidéo en continu dans la chambre du patient pour un monitoring vraiment pendant toute la période de son post-opératoire. Une continuous.
So yeah, the idea is to do it continuously, eventually, if it pans out as successful. Great. Merci beaucoup, Armel. Thank you very much. Our next speaker is Hannah Stevens, and Jen, feel free to step in. But Hannah is a medical student at Dalhousie who has looked at extubation to high flow nasal cannula in infants after cardiac surgery.
Hello, everyone. I'm just gonna try and share my screen there. Okay. Okay, can everyone see everything there? Great. Okay, so my name is Hannah Stevens. Thank you for the introduction. I'm a third-year medical student here at Dalhousie University. And my project is entitled Extubation to High Flow Nasal Cannula in Infants Following Cardiac Surgery, a retrospective cohort study. So we'll just jump right in, and I have no conflicts of interest to disclose. So for those who may not know, high flow nasal cannula, or high flow for short, is a way to deliver high oxygen flow rates by heating and humidifying the air that is delivered through nasal prongs. It's a relatively new intervention in pediatric intensive care units, first introduced around 20 years ago. It's a commonly used mode of ventilation for patients after extubation before transitioning to low flow or breathing room air. However, for how often it's used, relatively few studies have looked at whether extubation to high flow instead of low flow oxygen is actually beneficial. So up to 50% of patients are treated with high flow in the PICU are infants with congenital heart disease, often admitted following cardiac surgery. So these infants are at a higher risk of extubation failure, often associated with cardiac dysfunction, lung disease, and airway obstruction. And in this population, high flow is thought to provide increased respiratory support and physiologic advantages over low flow oxygen. However, to the best of our knowledge, only one prior study has compared outcomes of infants extubated to high flow and low flow following cardiac surgery. And this study focused primarily on blood gas values. So the objective of our study was to determine whether high flow provides clinical benefit over low flow in infants being transitioned from intubation and PICU following cardiac surgery. So this was a single center retrospective cohort study, and it was approved by the IWK Health Research Ethics Board. The setting was the IWK PICU, which is an 8-bed mixed general and cardiac PICU that admits about 400 patients a year, with about 70 of them being after cardiac surgery. So patients less than a year old who underwent planned extubation in the PICU following a cardiac surgery from 2014 to 2018 were eligible for inclusion. And for our study, we defined cardiac procedures as those involving either a sternotomy or a thoracotomy. And for infants who had multiple cardiac surgeries during the study period, each PICU admission was classified as a unique encounter. And then for patients who had multiple cardiac procedures during the same PICU admission, only the first extubation following the last cardiac procedure was considered. So from this list, patients were excluded for the following reasons. If they were extubated directly to non-invasive positive pressure ventilation, if they were extubated in the context of withdrawal of life-sustaining therapy, or if they were receiving home oxygen immediately prior to their hospital admission. So from there, a chart review was done to extract information about each patient's past medical history, cardiac surgery, PICU admission, and discharge. And for our analysis, the cardiac surgeries were classified according to the Society of Thoracic Surgeons and European Association of Cardiothoracic Surgeons categories. And we calculated the severity of illness on admission to PICU using 2 different scoring systems, the Pediatric Index of Mortality 3 and the Pediatric Risk of Mortality 3 scores. So patients were grouped according to their initial mode of post-extubation respiratory support, either high flow or low flow. The groups were compared to determine baseline differences, as well as differences in our 2 outcomes of interest. Our primary outcome was post-extubation PICU length of stay, and then our secondary outcome was rate of treatment failure. We defined that as the need to escalate from the initial mode of post-extubation support. So all statistical analyses were done using SPSS software, and basic comparisons between the groups were done using t-tests and Fisher's exact test where appropriate. And we also wanted to assess the effect of potential confounding variables on our outcomes. So we performed an analysis of covariance on the 2 groups. For potential confounders, we chose variables that were clinically important or those that had been shown to be significant in the unadjusted analysis. So we have kind of a flow chart that shows the process of study inclusion and the pathway of patients through different therapies. This first part just shows the number of patients that were included initially. So 171 patients met the initial inclusion criteria, and 136 patients were eligible after applying the exclusion criteria. And of those, 72 were extubated to high flow and 64 were extubated to low flow oxygen. So these groups were not significantly different in most baseline characteristics. One of the 2 significant differences between the groups was in the duration of cardiopulmonary bypass time during surgery. 151 minutes for the high flow group compared to 108 minutes in the low flow group. So this difference is despite a similar distribution of STS categories between the 2 groups as seen on this slide. And the only other significant difference between the 2 groups in terms of baseline characteristics was in the duration of intubation. The high flow group also had a longer mean duration of intubation at 3.2 days compared to 1.6 days in the low flow group. So for our primary outcome, there was no significant difference in post-extubation length of stay between the 2 groups. The mean post-extubation length of stay was 3.3 days in the high flow group compared to 2.6 days in the low flow group. And the significance of this was unchanged after adjusting for potential confounding variables using the analysis of covariance. So this next part of the flowchart shows the number of patients that had each treatment in the high flow and low flow groups. For the high flow group, 65 patients were weaned to low flow and 6 failed treatment. Of those that failed treatment, 2 patients were escalated to non-invasive positive pressure ventilation and then reintubated, and 4 were reintubated directly. And then for the low flow group, 55 patients remained on low flow and 9 patients failed treatment. And of those 9 patients, 2 were reintubated directly. 1 was escalated to high flow and then non-invasive positive pressure and then reintubated. And then the other 6 were escalated to high flow and then subsequently weaned back to low flow. So the reasons for reintubation were similar between the 2 groups. Airway obstruction and respiratory were common to both groups. And then 1 patient in the high flow group had a neurologic apnea that required reintubation. So for secondary outcome, there was no significant difference in treatment failure between the two groups, with 6 patients in the high flow group compared to 9 patients in the low flow group failing treatment. For the high flow group, all 6 patients that failed treatment required reintubation, whereas in the low flow group, only 3 out of the 9 patients that failed treatment ended up requiring reintubation. And for the patients that were reintubated from both groups, the mean time from extubation to reintubation was similar between the two groups, about 9 hours. And for high flow patients that did not fail treatment, the mean time to wean from high flow to low flow was about 1.7 days. So moving on to kind of the discussion points. So although not a significant difference, the high flow group did have a trend towards longer post-extubation length of stay at 3.3 days compared to 2.6 days. This raises the possibility that these patients were sicker in some way that wasn't quantified by their PIM or PRISM scores, and that they did require more support for a longer period of time. And this is also seen in the fact that the high flow group had a longer mean bypass time and a longer mean duration of intubation. These results suggest that the patients in the high flow group may have had factors contributing to their overall disease burden that were unaccounted for in our analysis. And if we make the assumption that the patients in the high flow group were sicker in some way, then it's possible that high flow therapy provided relatively more support to these patients and allowed more of them to remain extubated than if they had been extubated to low flow initially. So high flow may have been beneficial for these patients that were at a higher risk of extubation failure. And then in the low flow group, high flow therapy seemed to have functioned as an effective rescue therapy, where out of the 9 patients from the low flow group that required escalation of therapy, only 3 ended up progressing to reintubation. So for the subset of low flow patients that ended up requiring more support, high flow was beneficial in helping them avoid reintubation. And with all these questions surrounding like the routine use of high flow and when it should be used, the question of cost effectiveness comes up as well. So we didn't do a complete cost effective analysis, but at our center, we know that just opening up a high flow circuit costs about 9 times more than opening up a low flow cannula set at about $90 to $10. And that's without considering the day-to-day cost of running either system. So any opportunity to optimize the use of high flow for those patients that will benefit the most would be hugely cost saving over time. So there are a lot of different ideas and suppositions that can be drawn from our data, but the study is limited in scope and generalizability. It was a relatively small sample size at a single center, and it was a retrospective study. Additionally, during the study period, there were no protocols in place for when high flow was used in like what patient categories and how high flow was weaned to low flow. So, and as previously discussed, there were potential confounding factors related to intraoperative course, organ dysfunction during PICU stay, and then respiratory parameters on extubation that may have affected whether someone was extubated to high flow or low flow. And we didn't account for these in our analysis. So further study should investigate the use of high flow under relatively more controlled settings where possible. So our results, both in terms of post-extubation length of stay and rates of treatment failure, do not clearly indicate a benefit to high flow as a mechanism of post-extubation support compared to low flow oxygen. High flow may be beneficial as a rescue therapy for patients that fail a trial of low flow or for certain subsets of higher risk patients. And further research is needed to confirm our results in larger cohorts, as well as look further at which subsets of patients may benefit from extubation to high flow. So that is all I had. Thank you for the opportunity to present, and I'll now take any questions.
Great work, Hannah. That was very exciting and great to see you present such a clear presentation. Obviously, if people have questions, put them up in the Q&A box at the bottom. I'll start. A bunch of patients probably in your unit were extubated to non-invasive ventilation of some sort, say BiPAP or CPAP. How do you think those patients were different than the patients who were extubated to say high flow or low flow?
So actually, the interesting kind of thing that came out from our data is, so in the initial kind of catchment of all the patients, the 171 that met our like criteria for cardiac surgeries and things like that, I think we only ended up having 1 patient over the whole 5-year study period that was extubated to either BiPAP or CPAP. So it actually doesn't happen that often in our center for one reason or the other. But I could definitely see that the patients that were extubated to kind of non-invasive ventilation would be ones that, you can look at them right from the outset and know that they're going to be sicker over time, and then would require more support. That just doesn't involve having like being intubated. So, and that's kind of what we were looking for, to see if like the high flow patients in our high flow group were sicker in some way, which it's kind of inconclusive from our data, but yeah.
Yeah. Ben's question about whether or not there's any patients who were extubated to high flow for any specific reason, namely for delivery of nitric oxide or something like that. And if you don't know the answer, Jen might know the answer too.
Yeah, so I don't think we didn't record that data, and that's kind of one of the limitations that we do recognize with our studies, that we don't have any data on kind of at the time of extubation, what parameters are our clinicians looking at to say we are extubating to high flow or we're extubating to low flow oxygen. So yeah, I'm not sure on the numbers of those. Yeah, Jen, if you maybe have more.
Yeah, I can address that. We don't, I really think that in general, there is a clinician gestalt of this is a tiny kid whose nutrition's probably not optimal, and so we should probably extubate them to high flow. We don't routinely extubate to high flow to deliver nitric specifically, because usually we'll have to transition them to sildenafil when they're ready for extubation.
Did you notice any time-based changes in practice? I know that our practice has changed over the period of your study about the use of high flow. Was your center similar?
I'm just trying to think back to kind of as we went through. I think it was pretty consistent through the 5-year period that it was actually like I collected all the data myself, and it would be like one high flow, one conventional oxygen, one high flow. So it was pretty evenly distributed between, and even the groups that we had, like it was 72 versus 64. So they were quite similar over the whole 5-year period. So I didn't notice any significant kind of increased uptake of high flow during the study period.
I think I've noticed that since 2012, we've generally abandoned non-invasive, other forms of non-invasive, and gone completely to high flow.
Yeah, and that, again, that is borne out in our data where we only had one patient over the whole period, granted, like under 1-year-old that was, in for cardiac surgery, that was extubated to non-invasive in the whole 5-year period, so.
I have a question, Hannah. If you were to design the prospective study, how would you do it?
Yeah, so I think kind of learning from the retrospective a study that we were able to do with a prospective study, you'd have the opportunity to control for all of the parameters that we kind of have question marks about right now. So it would be probably over the same 5-year period, but you'd be able to say for a certain subset of patients with these respiratory and these severity of illness parameters at the time of extubation who have been intubated for less than this many of days or things like that. And then we'd be able to randomize them to either high flow or conventional oxygen or low flow, and see how they go and look at the same outcomes, post-extubation length of stay and treatment failure, extubation failure. So yeah, having that kind of perspective design where we're able to control for the parameters that we had question marks about in this study, whether it be like the intraoperative course or the duration of invasive ventilation, things like that, that we'd be able to control for going forwards.
Thank you very much.
I think that's probably it for our time, Hannah, but thank you so much. That was an excellent presentation, and to Jen and all your mentors, well done at having a clear presentation of good work. Thanks.
Thank you. Thanks.
So our final presenter is Camille Jutras, who is an ICU fellow here at Saint-Justine and who is a fellow also in the Clinician Scientist program. And Camille will be presenting her work on anemia after pediatric congenital heart surgery. Very apropos.
Thank you, Karen. All right, let me just share my screen. All right, so thank you everyone for still being here, even though I'm the last presentation of the day. Are you able to see my screen? Yeah, perfect. All right. So I'm pleased to present the result today of a study I did under the supervision of Dr. Dupont-Thibodeau, who is my mentor, on anemia after pediatric congenital heart surgery. I want to acknowledge the work of a medical student who worked with us and really helped us with the coordinating the data collection and with the redaction of the manuscript. So, first of all, post-operative care of infant after congenital heart surgery is associated with significant blood loss and often require blood transfusion. In the current era, as we discussed a bit earlier today, restrictive transfusion thresholds are increasingly being followed in PICU, but the ideal transfusion threshold in children with cardiac disease remain a subject of debate. Last ACSI recommendations were clear in regard to when to avoid to transfuse cardiac patient, but there is a lack of recommendation on a specific level at which we should transfuse this patient. One thing is clear, we are transfusing less than we used to, and the impact of this practice on long-term outcome is still unknown. It is well known that patients undergoing cardiac surgery in the early infancy are more at risk of long-term neurocognitive impairment. Also, anemia, especially iron deficiency anemia, has also been associated with worse neurocognitive outcome. In this context, we ask ourselves if anemia after cardiac surgery could be a possible contributing risk factor to neurocognitive impairment we're seeing in this population. The first step in answering this question is to describe the epidemiology of anemia at PICU discharge in patients with CHD. So this was the objective of our study, and we also wanted to describe a transfusion practice in infant undergoing congenital heart surgery. Our primary outcome was prevalence of anemia at PICU discharge. We defined anemia as per Canadian Blood Services criteria listed in the table here. And we used the last hemoglobin available before PICU discharge to determine if the patient was anemic or not. We did a single center retrospective cohort study at CHU Saint-Justin in Montreal from February 2013 to June 2019. We identify eligible patients through the NeuroCardiac Investigation Clinic database. The aim of this clinic is to offer follow-up for children who had a cardiac surgery with the objective of evaluating long-term neurocognitive outcome. We included infants less than 6 weeks of age who underwent congenital heart surgery with cardiopulmonary bypass. Patients with blood disorder, a neurologic disorder prior to surgery, or genetic abnormalities were excluded. For the results, we included a total of 119 patients throughout the study period. In this table, you can see here the patient characteristic and here the proportion with percentage, median with interquartile range, and mean with standard deviation. As you can see, mean age at surgery was 8 days, median age, at surgery was 8 days. And the most common congenital heart disease was transposition of the great artery, representing 55% of our population, followed by coarctation of the aorta and tetralogy of Fallot. Oops, sorry. I just want to hear the other categories included a patient with complex congenital heart disease, as for example, Dorv with mitral atresia. 6 out of 10 of these patients were cyanotic at PICU discharge. Median RAC score was 3. Bypass time and cross-class clamp time were respectively 165 minutes and 104 minutes. And median length of stay in the PICU was 7 days. In this table, you can see the prevalence of anemia at PICU discharge. Overall, 27.7% of our cohort was anemic at PICU discharge. This is less than what has been reported in the pediatric literature, where the incidence of anemia in PICU survivor for pediatric patients varies between 50 and 60%. Also, 30% of the patients that were transfused while in the PICU were still anemic at PICU discharge. TGA and truncus had the highest proportion of anemic patients at PICU discharge. Furthermore, none of the patients with HLH were anemic according to standard definition. Here, this is a bit of an inevitable. I'll guide you through it. So here you can see the hemoglobin value at different time over the PICU stay. We have the diagnosis here on your left, and then we have the hemoglobin value before surgery, at PICU admission, and at PICU discharge. I specifically want to highlight two aspects here. First, here, what we can see is that almost all patients experience an around 20 gram per liter drop in their hemoglobin level in between their perioperative period and PICU admission, except patient with HLH who had an hemoglobin at PICU admission that was 30 points higher than their hemoglobin prior to surgery. Second point I want to highlight is the hemoglobin values at PICU discharge. Mean hemoglobin level was mainly between 110 and 120 gram per liters in all patients, except once again in HLH patient who had a mean hemoglobin at 141. A high hemoglobin at discharge in the only category of patients that were cyanotic is logical, but we were surprised to see a different tendency in regard to the perioperative hemoglobin drop in this group. We also represented the distribution of hemoglobin at discharge on this graph. So you have here on the x-axis the hemoglobin value, and on the y-axis the number of patients. And as you can see, 23 children had an hemoglobin inferior to 100 at discharge. The last table I want to present is table 4, where you can see detail on RBC transfusion per diagnosis. So we have a diagnosis also on the left, and then we had the proportion of patients who had at least one transfusion, the number of RBC transfusion per patient, and the total volume of RBC over their PICU stay. A total of 58% of patients receive at least one RBC transfusion while in the PICU. Patient with HLH and truncus were the category with the highest proportion of patient transfused, with 100% and 86%. And patient with HLH, truncus, and the other category were also the patient that received the most number of transfusion per patient, as well as the highest volume, which is quite logical given the fact that they were transfused more. All right. To summarize, close to 30% of infants who underwent congenital heart disease surgery are anemic at PICU discharge. The prevalence of anemia varies depending on the diagnosis. TGA and truncus were more likely to be anemic at discharge, and no hypoplastic left heart syndrome were anemic when they left the PICU. 19% of the patient had an hemoglobin lower than 100 gram when they left the PICU. 58% of patients received at least one RBC transfusion while in the PICU, and a drop of around 20 gram per liter of hemoglobin was frequently observed in the different groups in between the preoperative period and the PICU admission. Even if these data are purely descriptive, they raise interesting questions. First, infants undergoing congenital heart surgery are frequently transfused, as we showed. Given the possible consequences of RBC transfusion and on outcomes, and as we discussed a bit earlier today, I think it is important that we continue to try to find the optimal transfusion threshold in this population, taking into account their specificities. Also, despite transfusion, close to 1/3 of the patients that receive RBC while in the PICU are still anemic at discharge. Anemia, as I stated a bit before, is the risk factor for worse neurodevelopmental outcome. The Canadian Pediatric Surveillance Program suggests a systematic screening of anemia in patients at high risk between 6 to 12 months of age. Infants who underwent cardiac surgery could certainly benefit from such a screening. To our knowledge, at least in our center, there is no standardized screening for these patients. Awareness regarding this issue should be raised in practitioners taking care of these children after PICU. Furthermore, we can ask ourselves, can we apply the same definition of anemia to the patient with congenital heart disease after PICU discharge? These patients have potentially have limitation of their compensatory mechanism to increase oxygen delivery. Restrictive transfusion threshold have been proven safe in the acute period, but is it okay to tolerate these hemoglobin level in time? Should we aim for higher hemoglobin in the long-term period? Furthermore, it remains unclear what is the definition of anemia in cyanotic patients, and should it be only based on an hemoglobin value? By using conventional definition, are we underestimating the proportion of cyanotic patient with anemia and not treating them appropriately? Also, is it okay to tolerate this drop in the perioperative hemoglobin level? In the adult population, adults who underwent a cardiac surgery, a decrease of 50% of their hemoglobin or more, despite maintaining an hemoglobin higher than 70 grams per liter, was associated with worse outcomes such as in-hospital mortality, stroke, myocardial infarction, and renal failure. So this study is the first study to generate specific data on epidemiology of anemia and transfusion in cardiac surgery infant. In addition, it also provides information on each of these aspects in relation to the different congenital heart disease. There are some limitations. It is a really small study with a small cohort and a retrospective design, and it was underpowered to detect risk factor associated with anemia at PICU discharge. It is, though, the first step in establishing the impact of anemia at PICU discharge in cardiac surgery infant, and there is still a lot of questions to be answered. First of all, we need to determine if this anemia persists in time after PICU discharge. We also need to better understand what is the predominant physiopathology of anemia at PICU discharge, as it could be explained by multiple things such as frequent blood sampling, iron deficiency, or anemia of critical illness. Understanding the physiopathology better will help us establish what is the ideal preventive or therapeutic measure to address this problem. At last, we need to determine if anemia is a possible reversible risk factor for long-term neurocognitive disability, and if so, how can we address it? Thank you.
That was really great. Thank you very much for the presentation. Remind everybody to stick their questions in the chat boxes. I just have a really quick question, just generally about, before you started looking into what the incidence of transfusion was after cardiac surgery, did you have a sense of what the unit practice was for transfusion in your cardiac patients?
Yeah, so we are, I think, just in the study that where, the center where Dr. Lacroix used to work, and we are pretty sensitive to transfusion and being restrictive in our approach. So I would say that, in our center, we normally do not transfuse or ask ourselves a lot of questions before transfusing a patient, because we're really concerned about this aspect. I don't know if we have data. I'm not sure about what we're doing compared to other centers. I think it's mostly like we're following recommendation, but I would say that we're more on the side of using the restrictive approach, for sure.
Okay. There's no questions yet from the audience. I had another one. Have you thought about, so you had talked a little bit about the likelihoods that you were going to, the likelihoods of different people getting transfused. Have you thought as you're going forward how you're going to present that in an analysis?
Of being transfused, like what is the criteria that we use to transfuse patients?
Sorry, I haven't made myself clear. Like when you present your analysis, have you thought about the statistics that you'll use? Are you going to use likelihood ratios or odds ratios or?
So actually, when we were looking at our data, it is a small cohort, and as each group is really small, it is difficult to compare them like in between groups. So we decided that we would report these data only as descriptive data and not do statistical analysis on them, as it is a really small cohort.
Okay.
I have a quick question, and I think Guillaume's questions echoes it as well. Did you look at either intraoperative transfusions and level of anemia, and then subsequently in the ward, what their anemia was, as Guillaume is asking, and if they did anything differently?
Yeah, that's an excellent question. So from the database that we had, we did not have the level in the operated room. And from what I've seen when looking at the data and looking at the patient's file, it is not that often that there is an hemoglobin level in the operative room in our center. Most of the time we only have one, and it's one close to the PICU admission. So it was often similar to the data that we had when they got into the PICU. For the portion afterwards, this is not something that we looked at, but it's something that it's really, that is sure something that we have to look at in the future, because as I said, we need to determine if this anemia persists in time. So we're doing a similar project, but on the pediatric population right now. And we're not looking at what's happening on the ward, but we're looking at 2 months, 6 months, 1 year after PICU to determine if this anemia persists. But it's something that we have in mind because, you know, they get out of the PICU, but we don't know if the pediatrician on the ward transfuse them or if they give them iron, and it can change them. It sure can change the impact of this anemia on the long-term outcomes. So this is why in the database that we had for this study, we did not have this information, but it's sure something that we're going to look at in further study to try to determine the impact of it.
There is a question from the audience from Gurpreet, who asked if you looked at adverse events with regards to the transfusions that were given.
No, it's not something that we looked at for this specific study.
I had a question, Kenny. I know it wasn't what you were specifically looking at in this study, but the hemoglobin levels are pretty far from restrictive, even if we're apparently a restrictive center. Do you think this is a reflection of the age of the patients, or how would you explain that?
I think it would be my like principal guess, because these children are less than 6 weeks of age. So I would say, I think this is, I think you're right, Karen, it's probably because they're young patients. And this is, as I said, this is the hemoglobin at PICU discharge and not the hemoglobin before a transfusion. We do not have the level of hemoglobin before each time a patient was transfused. So it's difficult to make assumption that it's close to, or that these patients were transfused at higher level than what is recommended, to make an assumption on what is our practice in transfusing this patient in our center from the data that we have.
And do you have any plans for sort of future studies or next steps?
Mm-hmm. So yes, so as I said, we are now doing with Dr. Thibaudot a prospective study on the pediatric population, not the cardiac population for now, because we choose to concentrate on the pediatric population at first, because there's a proportion of anemic patient that is higher. As I said, it's around 50 to 60%. And we're following them in a prospective manner to try to see if they remain anemic. We're dosing, measuring their blood parameters to determine if it's more of an inflammatory versus iron deficiency. And we're following them with neurocognitive testing to see if there's an impact of anemia in the long term. Once we have these data, which will sure be really interesting, I think we'll try to apply them to the cardiac population, but keeping in mind that it is a population with a lot of confounding factors and a lot of different aspects that could come into play when looking at neurocognitive impairment.
It's certainly an area of interest. I think we have almost daily ward round arguments with varying members of cardiac sciences on, no, we shouldn't transfuse. Yes, we should transfuse. Push the hemoglobin up. They're fine. Don't. It's daily. There's another question from the crowd on if you have any postulations on why the hypoplasts had post-surgical increase in their hemoglobin.
This is a question that we ask ourselves, and we add some hypotheses, but the main one that remained, and we were supposed to ask like the cardiac anesthesiologist to see with them, but we were wondering if the fact that these patients remain cyanotic after the surgery, is it for them incentive to transfuse them more, or to be in the operating room? But honestly, this is like the only thing that was, this is our hypothesis, and also that the fact that the heart, this is one of the pathology where there is no correction and no improvement in the heart function after Norwood or whatever. Is it also an incentive for anesthesiologists to give more blood in the OR? This was a hypothesis.
Thank you very much. So I think I see the time going forward. Thank you to all three presenters. I think there were three excellent presentations, and I'll pass it back to Baruch.
Wonderful day. I mean, we started with a vision of a future, and we went to the future telling us what we need to look at. So it was a wonderful day, super well organized. I do want to thank Shalin, who is our technical wizard. It was flawless. There was really no issues in terms of technical support and how the presentation, better than when live presentation. So I really congratulate her. And the two things, tomorrow, we will start around 11:50 in terms of ramping up, Mountain Standard Time, 2 o'clock Eastern Standard Time, and or 1:50 Eastern Standard Time. We're starting the meeting at 2 Eastern Standard Time or 12 Mountain Standard Time. There will be a prize for the best abstract, and I think Stephen is going to have the honor and pleasure of presenting that tomorrow. So everybody come back. We have another wonderful day planned for tomorrow with some great presentations. And I want to thank everybody. I want to thank the organizing committee. Really, it's been a pleasure.